FACS, and registered with the UK General Medical Council. His clinical focus include rapid diagnosis of breast cancer, breast conserving surgery with oncoplastic techniques, risk-reducing surgeries, and constructions. He has presented extensively at international conferences and published widely in peer-reviewed journals, reflecting his commitment to advancing breast surgery practice. His recorded lecture is with us, so I'm going to play that.
Good morning. My name is Mohammad Ashraf. I'm a consultant oncoplastic breast surgeon in Peterborough, UK. I'm grateful to the organizing committee for asking me to give a talk on rectal carcinoma in situ. I would have loved to be there in person in Lahore. But my apologies that I'm far away, but I'm still trying to contribute through the video recording of my presentation. So for this talk, I do not have any conflict of interest. What is DCIS? The rectal carcinoma in situ is basically a non-invasive malignant proliferation of epithelium, which is confined to the duct. So the way I describe it to my patients is that it is cancer cells which are developing within the basement membrane. They are not crossing the basement membrane, they are staying within the ducts. And they are pre-cancerous. They are not actually invasive cancer. The DCIS cells have the potential that it can convert into invasive cancer. In the West, amongst the screen-detected population, 20 to 25% have DCIS only. Whereas in Pakistan and other Eastern countries, the predominance of DCIS diagnosis is in the symptomatic patients, that they will present with a lump, and then some of them will have a diagnosis of DCIS. There is a great biological heterogeneity about the DCIS pathology. I will talk about that shortly in the next two slides. The overall survival of DCIS is excellent. 98% are alive at 10 times. So what are the grades of DCIS? Traditionally, they are described as low grade, intermediate grade, high grade. Low grade are, they have small nuclei without any necrosis with fine calcifications, whereas high grade have large pleomorphic nuclei. There will be necrosis, and some of them have what is described as central comedonecrosis, and they usually have coarse calcification. Intermediate grade is in between the two. So what is the natural history of and biological heterogeneity of the DCIS? DCIS has a risk of progression to invasive cancer. We are commonly asked by the patients that if it's untreated, when is it going to turn into invasive cancer? And I usually answer that we do not know the answer, we do not have the exact answer to this question. Sometimes it can convert into DCIS already at the time of development of DCIS, where it's already converting into invasive cancer, whereas in majority of patients it may take a few months and sometimes even years before it will turn into invasive cancer. The progression risk is dependent on the type of DCIS, so the higher the grade, the higher the size of the DCIS, the higher the chance of conversion into invasive cancer. Long-term observational data suggests that low-grade DCIS has slow progression and high-grade DCIS has higher risk of conversion into invasive cancer. Majority of DCIS, similar to invasive cancers, is ER positive. HER2 overexpression is quite common in DCIS. It is more common than the invasive cancer, and the molecular subtypes of DCIS are almost the same as those of the invasive cancer. So how is DCIS diagnosed? In the modern world, most of DCIS is diagnosed based on the screening mammography. It shows up as clusters of microcalcification, which is the gold standard appearance of DCIS on the mammography. MRI may be useful in some patients where the extent of disease and surgical planning requires further deeper imaging. In some areas where screening mammography, such as in Pakistan, is not common, then patients present with breast symptoms such as a lump or a nipple discharge, and when they have triple assessment, some of them are diagnosed with DCIS only without the invasive cancer. The diagnosis is confirmed with a nasal core biopsy, and if it is a lesion which is only visible on mammogram and not shown on the ultrasound, then the biopsy is targeted with stereotactic guidance or with the help of mammography, usually with vacuum assistance. Those who are diagnosed with DCIS and they end up having surgery, 15 to 20%, 25% will have an upgrade of the diagnosis at the time of surgery, that they will also be found to have invasive cancer along with DCIS. There are many risk stratification models of DCIS, but they all are based on the fact of the clinical pathological factors. So for younger women with high grade and lesion size around 4 centimeters or bigger, these add poor pathologic factors. And after surgical exclusion, if the margins are positive or close, that's an independent poor prognostic factor, unless someone goes back and clears the margin. Necrosis is also considered to be an independent poor prognostic effect. The modern stratification models include genomic assays such as Oncotype DX scoring, which can predict local recurrence risk and help tailor the adjuvant treatment such as radiotherapy. The emerging AI-based models, they are also helping in the stratification model. These are the list of traditional risk stratification models for the DCIS, namely Van Noy's prognostic index, clinical pathological risk factors, memorial flow scattering mammogram, pathology-based stratification, and imaging-based indicators. They all have limitations that they can predict the local recurrence, but they cannot predict the invasive progression or even the survival outcome of DCIS. So where is the role of Oncotype DX in DCIS? We know that the genomic testing, Oncotype DX genomic testing, has established roles in early stage breast cancer in terms of predicting the benefit of chemotherapy or not. But for DCIS, this 12 gene genomic assay is performed on the excised DCIS tissue, and it provides 10 years local recurrence risk, can separate them and stratify them into 3 different groups, such as the intermediate and high group can possibly be offered radiotherapy, and low risk group can be omitted to have radiotherapy. It unfortunately still cannot predict the overall survival, and it should be considered as an adjunct to the other factors, clinical pathological risk assessment factors that we already know. So how is DCIS treated? The gold standard is breast conserving surgery when it is feasible, when the DCIS is localized in limited area, and when we have the acceptable cosmetic outcome. The modern oncoplastic surgeries, mammoplasty, perforator flaps, they can all be employed for appropriate excision of the DCIS. The margin standards are not universal worldwide. 2 millimeters is considered to be the traditional acceptable margin, whereas increasingly acceptable no ink on tumor in selected low risk cases has been seen throughout the world. And if you differentiate them, if you divide them in the UK guidelines versus US guidelines, there are subtle differences. In UK, the 2 millimeter margin by default is considered as a preferred option, whereas in US it is almost strongly recommended. And no tumor on ink is rarely acceptable in US practices, whereas it is acceptable in selected low risk DCIS in UK practices. So far there is rule or consensus on the acceptable margin. But the studies have shown that the greater the width of margin beyond 2 millimeters, the lower the chances of local recurrence. So when is mastectomy required for DCIS? When patients have multicentric disease, when the DCIS involves a rather wide area of greater than 5 centimeters, there is a patient who has had surgical excision, their margin is positive, and you're offering re-excision. And if they have persistent positive margins, usually after 2 surgeries, the preference goes to mastectomy. Some patients will have their personal choice of mastectomy even for small area of DCIS. Some will even choose to have bilateral mastectomy and immediate reconstruction. And in those patients who already have had radiotherapy, there is contraindication to radiotherapy, so they can choose mastectomy. And the options could be simple mastectomy versus a mastectomy where they can have immediate or delayed reconstruction, such as skin or nipple mastectomy. So when is sentinel lymph node biopsy advised in DCIS? It is not a routine procedure for DCIS. It is only recommended if mastectomy is planned. And even now, things are modifying and changing. So in our practice, in our hospital, even for mastectomy, we are not routinely doing DCIS, we are not routinely doing sentinel lymph node biopsy for DCIS only. What we do is we inject them with MAGTRACE, which is localization molecule based on iron fumarate. Before the surgery, they undergo mastectomy, and then we wait for the result. When we get the result in the mastectomy specimen, we go back and do sentinel lymph node biopsy, which is localized with the studies. The largest area of mass formation of high-grade DCIS is also considered as an indication for sentinel lymph node biopsy when they are undergoing breast conserving surgery. What is the role of radiotherapy in DCIS? It reduces the risks of ipsilateral recurrence by 50%, a huge reduction, although it does not provide any overall survival benefit. It is still considered a standard of practice to provide radiotherapy in patients who have breast conserving surgery. However, it can be possibly omitted in patients who have low-grade DCIS with very clear margins in older patients where the disease is ER positive. Endocrine therapy such as tamoxifen or aromatase inhibitor has been used in the DCIS treatment. The benefit is that it reduces the ipsilateral and contralateral recurrence. However, again, it does not provide any survival benefit. The low-dose tamoxifen, which is 5 milligrams instead of 20 milligrams, is also gaining acceptance due to reduced toxicity. The NHS or UK standard does not include endocrine therapy. It is a US standard where patients are treated with endocrine treatment for DCIS. In the modern world, there are trials going on in the pursuit of active surveillance of DCIS, which means that for mostly for low grade or some, according to some studies, intermediate grade DCIS is localized disease. Patients can be followed rather than having surgical experience. And these trials are running in UK, USA, in Europe, as well as Japan. And they have their goal is to identify safe patients where surgical experience can be easily omitted. And the key question that they have to address is what is the long-term invasive risk in those patients if it can be omitted, if the surgery can be omitted. Can this be applied to low-grade as well as intermediate grade DCIS? And how is the area followed? Do they have regular mammograms or do they involve regular biopsies? And what are the psychosocial impacts on patients? So the message from today's presentation should be that these trials are still actively undergoing, and this is still under investigation. It has not become standard of care. So what are the outcomes and prognosis of DCIS in modern world? The breast conserving surgery reduces the local recurrence by 15 to 30%. whereas patients who have breast conserving surgery and radiotherapy, their local recurrence rate is only 5 to 10%, and mastectomy can reduce the local recurrence rate to less than 2%. Overall survival is excellent, more than 98% at 10 years, and increasing emphasis these days is being given to the long-term toxicity of the treatment, psychological impact of the treatment, and patient-reported outcomes in this treatment. The controversies in DCIS are still persisting in terms of its diagnosis. Is it a cancer, or is it a pre-cancer condition, or is it a risk marker? Then there is debate on the overtreatment versus oncological safety of surveillance strategies. Then there is controversy about the optimal margin width, as I described earlier. And finally, the role and possibly overuse of sentinel lymph node biopsy is, and it remains as a controversy in the management of DCIS. The future directions are that biology is the king, and biology of the DCIS may be guided by the Oncotype DX, should be helping the surgical decision making. The active surveillance protocols, according to the study, should provide and expand on the future. Minimally invasive local therapies may become easily available in most places to get rid of DCIS, and then reclassification and improved patient communication should be the key for future development. So the take-home message is that DCIS is not one disease; it's biologically heterogeneous and a huge range of disease, and one size fits all cannot be the strategy. It should be tailored according to the disease extent and patient health condition. So the management should be risk adapted. Trend should be toward the de-escalation and personalization of specific treatment to individual patients. And towards the end, multidisciplinary decision making is essential, as is with any cancer patient in the patient. With that, I will conclude my talk. Thank you so much for your time, and again, apologies that I could not be there in person. Best wishes.
Really informative. If somebody have a question regarding DCIS, we have expert panels. Just here, anyone wants to have some question regarding DCIS? So moving toward the next expert is Dr. Fina Sono. She is Karachi leading breast surgeon with over 2 decades of clinical experience. She completed her MBBS, SPPS, and has served in top hospitals as Liaquat National Hospital. She is known for her work in multidisciplinary breast cancer awareness and care in Pakistan. Her research contributions span multiple studies and campaigns that have influenced breast cancer management. Her recorded lecture is with us, so she is also online with us on Zoom meeting. So if you want to have any questions, you can ask.
Assalamualaikum. I would like to thank the organizers for giving me an opportunity to be part of this conference. I am available online for any further discussions. Localization has evolved alongside screening because of use of neoadjuvant therapy and oncoplastic surgery has played a major role. The aim is to understand what exists, what works, and how to be used. Localization matters because we are able to identify smaller, non-peripheral screen-detected lesions. Oncoplastic surgery requires precise identification and location of the lesion, otherwise we might lose them. The goal is accurate excision and low re-excision rates, and it improves the workflow efficiency and patient comfort. We need to localize in non-palpable lesions, be it invasive or even extensive calcifications. And when we are talking about identification of large lesions, extensive DCIS, multifocal or multicentric, we at times need to localize, bracket them for complete excision. Neoadjuvant therapy, tumors may totally disappear. So we need to identify and localize the tumors and the positive nodes. And sometimes the lesions are only seen on MRI, so we need to identify MRI detected lesions also. We have to pick up lesions in the breast and in the axilla. There are various methods available with wire and without wire, and all these techniques are used worldwide. Wire-guided localization is the most commonly used procedure. Wire, it is easy, available, but it has got some challenges that we are going to discuss. Other methods, radioactivity maxes, these are non-wire, they also localize precisely. In wire-based, the radiologist insert a thin wire through the biopsy needle, and it is taped to the chest wall or abdomen breast, and the surgeon localizes with the help of that tip of the wire where the lesion is. It needs coordination between surgery and radiology, and but the thing to notice is, okay, although it is a approach, the wires comes out from the target area, a little away from that. And this is put if it under mammogram guidance, the mammogram it is put under compression of the breast, and when the compression is lifted off, it may not be at the precise place, wires can be destroyed. The advantages are it is widely available, surgeons are more familiar, radiologists are also used to it. It is not very expensive, but it requires complete coordination and same-day scheduling. It causes patients a bit of discomfort, wires may migrate, and restriction is on the your incision planning. Um, and if we are planning between these, OR may be delayed because of that. Intraoperative ultrasound, if it is available in the operation theater and surgeon has the familiar with the use of ultrasound, it is a very good technique for ultrasound detectable lesions, and it is dynamic, it is very precise in identification of the margins, so surgeons can easily excise that area without removing excess tissue. Intraoperative ultrasound is the real-time localization, cost is less, but surgeon have to be familiar and the lesion has to be ultrasoundly visual. Radioactive seed localization is usually a radioactive iodine 125 seed is placed with the help of the cannula under mammogram and ultrasound guidance by the radiologist. Flexibility of the time is available here. You can place it days before surgery, and intraoperatively gamma probe is used to identify where the lesion is. This is also very precise in localization. It has a radiation safety regulations that one needs to take care. Coordination with the nuclear medicine team is needed, and one needs to properly dispose of these needles. MACD localization is becoming very popular. CEDAR is deployed under ultrasound guidance, and that magnetic probe is MACD probe is used to detect where the lesion is, but one has to be careful about it because when you are doing it, you do not need metallic instruments near that, especially when the probe is placed on the MACD and it needs coordination. Cost is a major factor here, but otherwise it is very precise and very patient friendly, but the lesions which are only visible on MRI we can do MRI guided biopsy. Sometimes when the lesions are not visible on initial ultrasound, after MRI, if you go back and do the ultrasound again, we might be able to do ultrasound guided biopsy. But if it is not visible, one can use special instruments to do MRI guided biopsy. Very familiar with it. One can use the radar reflector to put in this, and scout console emits radar waves that detects the reflector, and thereby we can localize that. The key consideration is timing. Wire-free method allows placement days and weeks before the surgery. Patient is comfortable There's a surgical freedom. You can make the incisions where it is comfortable for the surgeon rather than where the wire is entering. And it can localize the lesions, but when they shrink even after chemotherapy. The other thing is that we need to localize axillary nodes. There are also various methods available for the identification of the nodes, and we are all using clip nodes, which are very important. Nodes, because we all know that nodes may disappear clinically and radiologically after the neoadjuvant therapy, and localization ensures accurate excision, and clip node and the sentinel node, what is called a targeted axillary dissection, definitely surely reduces the false negative rates in axillary node detection. So you put a node, clip in the positive node in the axilla, localize the node with the help of wire on the day of the surgery, and you remove that node along with the sentinel nodes to reduce the false negative rate. One may use even CT scan to identify the clip nodes if they are difficult to visualize on ultrasound. It also requires expertise but has to be done on the same day. MEC tracer can be used also to identify the sentinel nodes. What is done that on the day of surgery, on the 15 to 20 minutes before, special iron oxide soluble uh, is injected in the perialveolar area, like we inject methylene blue. Centimate probe is used on the table to identify the nodes, and these are the nodes which can be sent for then to the pathologist for confirmation of the pathologic disease there. One can even tattoo the suspected nodes, and the tattoo remains there for some time, and you can identify the tattooed node on the table. One can also use same Savi Scout to identify the suspicious nodes. So how do we decide? We decide if it is visible on the ultrasound. One may use intraoperative ultrasound or ultrasound guided via localization of the lesion. And if it is not ultrasound visible, one can use MEMO or MRI or other devices to use that. Clip node and the wire nodes are the most commonly available thing. The yellow highlighted maxi, radar, and radioactive substance if it is available. MRI guided facilities are available in very small centers. So there is enough of evidence that non-wire techniques that we have talked about, they are equivalent, non-inferior in terms of margin identification or re-excision rate. They may not be very superior, but definitely not inferior. Improve patient satisfaction and OR efficiency. Intraoperative ultrasound reduce positive margins in selected lesions. Targeted axillary node dissection reduces false negative rate and thereby improves the accuracy of the residual disease burden in the axilla. We need to confirm clip placed in the axilla and device position. Always perform specimen imaging after excision. Clear radiology, surgery, pathology communication is needed. We need to audit our re-excision rates, localization failures so that we improve further. So key take-home messages are that localization is central to the modern research field. Wire and intraoperative ultrasound remain valuable tools. New technologies that we have talked about surely improve workflow and patient comfort. Axillary localization enables safe de-escalation. We need to choose techniques based on our resources, expertise, and case mix. Most localization techniques are oncologically equivalent. This is what we need to remember. The real differentiators are workflow, cost, and infrastructure. In low middle income countries like Pakistan, value-based choices we have to make, intraoperative ultrasounds, wire-like localizations, and selective targeting the nodes with wires help us to deliver modern breast surgery without compromising patient safety. Thank you so much.
so much, madam. Madam is online with us. If somebody wants to have some question with her. Hello.
Assalamualaikum.
Ma'am. We have so many participants here. Anyone wants to have some question, madam?
I can see a lot of familiar people sitting there. Assalamualaikum to everyone. If there are any queries, I'll be happy to answer.
Assalamualaikum, Rufina. I came this morning hoping to see you here and we're missing you a lot. I wish you were here with us in person.
I'm sorry, I'm getting tempted. Why am I not there? Seeing you, Humayra, everyone over there. I wanted to be there, but I came here last week, so I thought it will pick up in too much.
Oh, we need to see you here soon again. Anyways, I just
Hope you all enjoyed.
thank you so much. My question was, what localization technique do you prefer and what are you personally doing these days in your practice?
I think I mostly use wire localization because that's the most easily available. But as I discussed in the wire localization challenges, your needle is coming from somewhere else, your lesion is somewhere else, which causes a little problem as compared to the other met seed and other things. That is directly hitting over there, so that makes in your surgical planning easier. But these are all expensive gadgets, and I don't think at the moment we have enough money to afford all that. So I mostly rely on radioactive methods, or if I'm stuck, otherwise intraoperative ultrasound sometimes, but mostly it is wire localization.
Thank you so much for joining us.
Thank you, it's a pleasure.
Our next guest speaker is Dr. Huma Majid. She served as a consultant breast surgeon and head of the breast surgery department at Park Hospital, Lahore. She is UK trained surgeon with MBBS and FRCS. And she's strongly expertise in managing both benign and malignant breast diseases, including oncoplastic approaches within general surgical practice. Her leadership in clinical care and training underscores her role in promoting advanced breast surgery techniques in Pakistan. My topic is going to discuss is nipple sparing mastectomy and skin sparing mastectomy updates and patient selection.
मैं कुछ अनकन्वेंशनल करती हूँ मगर अब मैं बहुत साल से कर रही हूँ आई डोंट डू वायर आई जस्ट डू एंड वी हैड हमारा लेस देन 2% पॉजिटिव डेटा बिल्कुल क्लीन डेटा हम दो क्लिप छोटा जो अगर छोटा ट्यूमर है 3 सेंटीमीटर से छोटा उसके सेंटर में क्लिप कराएं 3 सेंटीमीटर हमने ब्रेस्ट से आप 3 सेंटीमीटर और मोर उसके मार्जिन्स के दो क्लिप न्यू एडजुवेंट से पहले they come close after that and go for both the clips so if you go जो impenetrable हो जाते हैं especially triple negative में आपने देखा होगा histopath में आता है कि वो multiple fossa है वो that is the very dangerous so that has worked हम ऑन टेबल अगर वो बिल्कुल गायब हो गया है तो हम फाइनल उसमें वायर नहीं डलाते, हम हर थिएटर के अंदर आपका इमेज इंटेंसिफाई है, हम इमेज इंटेंसिफाई ला के उसकी पोजीशन कंफर्म करते हैं ऑन टेबल एंड देन वी जस्ट रिमूव इट एंड अगेन इन थिएटर। मेमोग्राफी को नहीं भेजते, अगर माइक्रो टेस्ट का इशू नहीं है तो वो भी वहीं पे कंफर्म हो जाता है स्पेसिमेन के अंदर एंड इट इज चीप and it has really worked for us और हमें डिपेंडेंस नहीं है और वो जो वायर कोई उधर से उधर यहाँ से डालते हैं आपने कहीं बार। सो आपका जो ऑर्थोपेडिक्स का एक्सपीरियंस है वो इसमें काम आता है। थिंक ऑफ योर रिमूविंग अ फॉरेन बॉडी, बेसिकली यू आर रिमूविंग अ फॉरेन बॉडी। सो So, हमने और लोग why do people go for reconstruction? How do we decide who needs what? And techniques we quickly because 10 minutes time मुझे बताते हैं and some just touching the complications and what is happening recently. So conventional mastectomy, nipples, skin sparing mastectomy and nipple sparing. Women seek reconstruction because of body image issues and quality of life and social issues. And age is not important. ये याद रखें। ये कह देना कि इसकी उम्र 50 साल हो गई है तो बस mastectomy कर दो तो that's not acceptable. Ask them what do they want. और late presentation जो है वो आधा इसीलिए होता है कि people are afraid to lose breast. इसलिए नहीं होता कि उनको ये होता है कि हम जाएंगे कुछ निकलेगा। The first thing is not that we will die. The first thing is oh I will lose my breast. और वो उनकी सारी community हर age में उससे लिंक है। So reconstruction cases को लोग time नहीं देते क्योंकि it's a very complex thing. You need to have time. You need to sit down with the patient. It's not easy. अभी उनको पता चला कि कैंसर हो गया, अभी तो उनका सर उसी में है. And then you are asking कि what do we do? हर कोई कुछ कह रहा है, कोई कुछ कह रहा है. So it's all very complex and very emotional sort of topic. और आपको उनको समझ नहीं आ रही होती कि पता नहीं हम बचेंगे कि नहीं. This procedure will this more sort of good for me. कोई कहता है जैसे BCS में भी जैसे कि पूरी ब्रेस्ट रिमूव करा लें तो ठीक हो जाएंगे. You know, so you have to give time to them to convince and cost. Cost is a problem. Again, I am a cheap surgeon, so I don't do implants for many reasons. And cost is one thing. And हम oncologists के जाते हैं ज़्यादातर, which is good. You will need plastic surgeon in most scenarios, but you can do it yourself. But for years I used to do it myself, and then now as I'm getting older, and I have fellows, so हम plastic surgeon हमारा part है. और वो फिर हम निकालते हैं वो डालते हैं. It's a very sort of करते भी नहीं है. It is a nicer teamwork, right? And sometimes you do need extended sort of reconstructions तो वो अच्छा है. So morbidity का उनको डर होता है. अच्छा तो you need time, you need facilities and skills. और इसमें से skills develop करना आपका काम है. और बाकी चीजें भी resource development भी आपका काम है. आपको कोई कुछ प्लेट में रख के नहीं देगा. Wherever you go, you have to यहाँ ये नहीं है is not the answer. मैंने क्या करना है और उसे develop कैसे करना है. Do that. So this may delay systemic treatment. Now this is very important. So always be very patient रहेगा. So आपकी timing दुरुस्त होनी चाहिए. Reconstruction के चक्कर में reconstruction कितनी भी अच्छी हो, इधर से नेपेंट का इधर से एंगल उसका खराब, थोड़ा सा डिले. So if a normal person can have chemo after 4 weeks, they may require it after 6 to 8 weeks. So can you wait? Is it like safe for the patient? Otherwise, go for delay. So prerequisites सबको पता है कि safety first, symmetry is important. हम बड़े fortunate हैं पाकिस्तान में dress code की वजह से women are not fussy. बाहर बहुत symmetry, contour, nipple projection. यहाँ पे if you give them a good volume, with reasonable aesthetics, they are happy. ठीक है, क्योंकि बाकी इतना matter नहीं करता. Contours और aesthetics को आपने this is not the topic, मगर nipple की position ये बताएंगे आपको. He's the guy who just walked in. So aesthetics, breast aesthetics क्या होते हैं और why, how can they work around it. So skin removal of breast tissue हम करें by saving the envelope. And sometimes we just can remove the nipple अगर कोई involved है और दूसरे में नहीं, we have to skin or nipple sparing. So it's the gold standard now. जहाँ पे भी mastectomy है, patient needs to know कि उसकी reconstruction हो सकती है, upfront हो सकती है या delayed, उसको बताना है, वो करवाए या ना करवाए, बहुत कम लोग करवाए, ये उसकी मर्जी है, but they need to know their options, they need to know उसकी safety, और आप upfront का क्या कर सकते हैं जहाँ पे indicated है, और जब delayed है तो वो क्या होगा, और when what is the time to seek it, so that they can remind you. Implant, autologous or a hybrid, you can use both. So indications of nipple sparing and skin sparing mastectomies are multicentric disease, BCIS भी हो सकता है, invasive भी हो सकता है, multifocal in a small breast जहाँ पे आपकी quadrilectomy is not going to be very good cosmetically, और even non-epithelial कोई आपका फिलॉइडीज टाइप चीज है जिसमें आपको mastectomy करनी पड़ रही है, skin is okay, तो why you can do this, मतलब there is no harm. और prophylactic में BRCA carriers are the main indicators, risk reducing surgery जो है, and very strong family history with multiple risk factors तो maybe, but ऐसे नहीं, if a patient comes and ये भी करते हैं, you just don't do it for money or fun. So that's not good. So absolute contraindications क्या है? Inflammatory, T4, nipple area, ये nipple areola infiltration by the tumor, infiltration, ठीक है? तो फिर आप ये नहीं करते, then you do it later on. और जो nipple sparing है उसमें अगर pages है फिर नहीं करेंगे, और अगर less than 1 centimeter, so पहले 2 centimeter का area था, अब ये हो गया कि they are becoming more sort of heroic and they are saying कि less than 1 centimeter अगर tumor नहीं है, so then you may not need to worry about it. So relative contraindications are, they absolute नहीं है, मगर अगर multiple हैं तो then you have to think. So older age में blood supply खराब होगी, skin quality खराब होगी, you know, it's not just the age, but you are looking at other things. And diabetics, जो भी कोई atherosclerosis, कोई शरीर आपको लगता है कि इसको vascular disorder है, autoimmune कुछ चल रहा है, large tumor है, close to skin, large rotic breast अब applicable नहीं है, that is again something new that now you can do like the reduction factor thing and still can do the nipple sparing mastectomy. Or recent surgery, multiple scars, smoking is a big sort of no-no क्योंकि उसमें vasoconstriction होती है, poor blood supply होती है, all sorts of plastic surgery. मुझे नहीं पता यहाँ बाहर वो तो पहले बंद कराते थे, आपको साबित करना होता था you stop smoking, तो फिर वो आपकी surgery होती है. So safety और aesthetics को हमने मिला के चलना है. अब patient selection क्या होगी? Patient होगा जिस समय आपने उसका tumor size, biology, naturally DCIS है कितना है, उसका distance from skin, nodal involvement, quality of skin, ये वही चीजें हैं, और breast size. So oncological safety में now we know कि चाहे वो conventional है, चाहे वो skin sparing है, चाहे वो nipple sparing है, there is no significant difference in oncological safety in either. अगर आपने patient selection की, याद रखें कि breast surgery में आधे 70% काम is your patient selection. The surgery is probably not that difficult. You even if I don't teach you, you will learn it in 6 months. मगर आप जो है आपने अगर गलत इलाज किया for wrong indications तो आपका मरीज जो है बीमार है. So it is more like a cancer surgery rather than just breast surgery. So that's very important. So right आपकी indications है, patient selection किसी भी surgical specialty में it should be done on the right patient. और तमाम studies अब जितनी भी आ रही हैं जो 2025 में ढेरों आई हैं, वो कहती हैं कि nipple sparing, skin sparing इनमें भी कोई फर्क नहीं. So अच्छा prognosis जब ये कहते हैं कि prognosis in favor of nipple sparing and skin sparing, इसका मतलब क्या है? मतलब ये है कि obviously ये low disease burden patient, ये नहीं कि उसका फायदा है, फायदा ये है कि वो लो डिजीज बर्डन है तो उन्होंने तो वैसे भी going to do well. जैसे BCS has better outcomes क्योंकि उसे रेडिएशन देते हैं, mastectomy में बहुत सारे So वो जो difference है, that is in patient selection. कब करते हैं हम immediate reconstruction में ज़्यादा हम करते थे, मगर अब हम increasingly post nipple, that's also new. जब nipple sparing, skin sparing आई थी, तो आप up front में करते हैं, अब आप post nipple भी करते हैं. So आपका incision जो steps हैं, incision कहाँ होगी? Axillary is the best if you are going to do an autologous जैसे LDMF वगैरह आप कर रहे हैं. Even implant के लिए कई लोग इसी को use करते हैं. But now they say कि अगर आपने implant करना है तो inframality. वैसे तो बड़े बहुत सारे हैं, मगर these are the only two practical ones. Do you use any other incisions?
I actually do like a slight modification of a back thing because I feel you have a flaps vascularity and all you end up is like two little lateral and medial wings that.
That's his skin sparing.
Skin sparing nipples.
दोनों में भी.
That's what I do. That's works out very well.
पर ऐसा अगर नहीं हो रहा, periareolar areas.
It's not really taking up too much skin, but that it gives me big area to work with, bigger area. I do my axilla to the same incision.
और especially larger breasts में इसका अच्छा फायदा हो.
And then I can do my reduction if I need to do it through the same incision. So it's worked very well.
So you guys will remember that. That's another sort of good thing to do. Tissue handling has to be very. आप जितना खींचेंगे उसको और वो जितनी diaphragm जो है आप ज़्यादा शीट पे रखेंगे वो that's not a good idea. Cutting से ज़्यादा आप काम करें, bipolar से ज़्यादा काम करें rather than so you have to indirect heat भी होती है, जो direct heat नहीं होती. अगर आपने कभी काम जो करते हैं, अगर आप अपने कभी diaphragm करें तो उससे भी coagulation होती है, उससे vessels खराब होती है. Quick reminder. ये आपको सबको बहुत अच्छा पता होना चाहिए if you're doing a skin sparing or a sparing. If you do not know, हमेशा blood supply को कोई lift ही नहीं कराता. Even taking through-cut biopsy, if you are hitting the wrong place, you are going to have disastrous hematomas in your breast. I have seen it. Disaster. अगर आपको पता है कि major vessels कहाँ से आ रही है, तो आप अपना ध्यान रखते हैं कि आपका हाथ कहाँ से जाएगा, तो सीधा से. So skin sparing में naturally you go all around. Skin sparing तो easy है, तो उसमें आप मतलब nipple is being removed. So main जो है flaps की thickness 2 millimeter, but it is no hard and fast rule. Remember कि blood supply जो है flap में जा रही है, उसकी fat है subcutaneous. So अगर आपने बहुत ज़्यादा dermis को denude कर दिया, तो it's going to be a problem. और ज़रा ज़्यादा छोड़ दिया, तो फिर वो breast tissue रह जाएगा. So it's tricky. So you are very happy जब जिनकी ज़रा ज़्यादा subcutaneous fat होती है. And people old age में आपने भी देखा होगा कि there is like very little subcutaneous fat. आप mastectomy plane में जाते हैं, वो सारा कुछ जो है ना वो dermis रह जाती है, वो हाथ में आ रही होती है fat. So that's the problem. So ये उसी तरह है कि आप जाएंगे, we are not doing the techniques in detail, मगर I use diathermy. और हम bipolar scissor भी use कर सकते हैं, which is a very nice thing to use. और harmonic scalpel या नहीं है, और भी बहुत सी चीजें. But these are the things which are more commonly used. और अब endoscopically assisted का operation मतलब आ जा रहा है. और you would know this is like a skin sparing first post-op day. This is 1 year. आप देखेंगे वो थोड़ा सुकड़ता है. Whenever you do जहाँ भी radiation देनी है, आपकी ब्रेस्ट जो है वो थोड़ी सी कितनी 10% to 20% के करीब उसमें सुकड़ जाना है. So you have to overdo a little bit. So skin और nipple necrosis हो सकता है, infection, hematoma, seroma, depigmentation, de-epithelial dermolysis सा होता है, epidermolysis. जहाँ से भी अगर nipple areola में epidermolysis very common, तो वो area white ही रहेगा, वो pigment नहीं होगा. You need to remember that. ये बातें आपने मरीज को पहले बतानी होती है. जब आप consent लेते हैं तो informed होता है. आपने उसे बताना है कि we are doing this. These are the possible complications. कम chance होता है, so that they are mentally prepared what to expect. Patient का upfront reconstruction में बड़ा false होता है कि they think कि they will wake up तो it will be like a normal breast, उसकी sensations and everything, वो जो नहीं होती. So वो आपने there has to be clarity about especially the sensation part. All these little very hard, especially in cancer patients. जो cosmetic surgery है risk reducing, उसमें तो आप बेहतर काम कर सकते हैं, मगर कैंसर में सिमेट्री लाना बहुत मुश्किल है, जो बाद में रेडिएशन की वजह से। So implant related आपको लोगों को पता है, किसी को आते हैं implant related complications का? एक long term भी होती है क्या होता है?
Capsular contracture
और रेडिएशन जब होती है, that's the biggest problem. एक seroma infection and capsular contraction. Long term में वो किस्म में malignancy is very rare, but so ये सारी बातें आपने मरीज को बतानी है. This is like a localized skin necrosis. मेरे patient ने जैसा मैंने पहली बात किया, मगर वो it was okay, did not need excision or anything, but this can happen. So अब जो हो क्या है, नई चीजों में न्यूरोटाइजेशन हो रही है. So the fancy plastic surgeons like Dr. Khalid, this might be argument, मगर ये कि अमेरिका में ज़्यादा रवाज है. They are trying to ताकि sensation में. So nipple की जो main sensory वो आती है, वो दो जगह से आती है, fourth stage से laterally और intramedullary से. तो वो nerves को identify करते हैं और बचाते हैं. और कईयों में वो कह रहे हैं कि ड्राफ्ट करें वगैरह वगैरह. So that's like fancy stuff, maybe not for us, but it is being done. And future में ये चीजें बढ़ती जाएंगी. Endoscopic minimally invasive option है. Robotic assisted मेरे ख्याल में वो डॉक्टर जैन की बात करेंगे. Cost is almost $3,500 ज़्यादा महंगा है. It's not cost effective. It's not time sort of. उसका कोई फायदा है. So you have to see कि आपका या तो टाइम बचता हो या कॉस्मेटिक आउटकम अच्छा हो और या कॉस्ट इफेक्टिव. मतलब अगर वो तीनों चीजें नहीं हो रही हैं तो फिर आपको चीज करने की जरूरत है. पर ये होता है and it's a good thing to learn this. क्योंकि बहुत सी जगह you can use it as an aid. ये नहीं कि आप पूरा ऑपरेशन उसको कर रहे हैं. Like in difficult scenarios. और अब प्री पिक्टोरियल इम्प्लांट्स का भी रिवाज ज़्यादा है. That is something new. पहले हमेशा पीछे रखते थे, but that also depends on the thickness of your skin flaps and what do you need to support it in the lower part. दूसरी चीज जो पेशेंट एलिजिबिलिटी जो अपडेट्स में ये है कि आप बड़ी लार्ज एंड प्रोटेक्ट ब्रेस्ट में आप रिडक्शन पैटर्न, जैसे आप रिडक्शन नामोप्लास्टी करते हैं, उस पैटर्न से भी करके आप स्किन स्टेरिंग कर सकते हैं. T3 was big no-no, अब नहीं है. So अगर वो डाउन स्टेज हो जाता है तो आप उसमें भी कर सकते हैं और सेफ डिस्टेंस तक 1 सेंटीमीटर पे आ गया. सो एंडोस्कोपिक वर्सेस कन्वेंशनल में कोई फर्क नहीं है. मतलब ऑल द डेटा सेज के अभी आपका कोई डिफरेंस नहीं है इन द कॉस्मेटिक. मतलब थोड़ा सा बेटर कॉस्मेटिक आउटकम है, मगर ऑन्कोलॉजिकल सेफ्टी में कोई फर्क नहीं है. लेस स्किन नेक्रोसिस में भी, क्योंकि जब आप एंडोस्कोपिक करते हैं तो जैसे लैब कोई वो आप इंसर्टेशन होती है तो प्लेन खुल जाते हैं. सो जब प्लेन खुलते हैं तो आप मेरे ख्याल में देयर इज लेस डिस्ट्रक्शन और आप यू आर बेटर ऑफ कि आप जो है उसी प्लेन में काम करेंगे एंड यू आर नॉट गोइंग बियॉन्ड इट. तो उससे शायद वेस्कुलरिटी का फायदा है. ये एक अच्छा मैंने देखा था, ये वैसे 7 स्टेप ये नेट पे है, इसको देख लें whoever is interested. I liked it. ये चाइना में काम शुरू हुआ था, अभी बहुत जगहों पे हो रहा है, अफ्रीका में भी हो रहा है, यूके में भी हो रहा है. But this is like a good sort of. So this is our nipple sparing with LDMF. ये first post op day है, Sentinel हुआ है तो इसलिए बोल नहीं रहा है. और अब देखिए इसमें मैं I can't really much because I'm limited. मतलब हमें थोड़ा सा छोटा जाना पड़ेगा because you have मतलब टिश्यू आपके पास इतना है वो है. And if the patient agrees, you can always do like surgery on the outside, symmetrization. Majority कहते हैं हमें जरूरत है, पर अगर कोई एक दो ने कराया भी है, आप ये उन्हें कह सकते हैं, you can do वो ठीक है, टॉटिक ठीक है, बड़ी है वो, that can be done. And this is like 6 months, तो radiation वगैरह हो चुकी है और it is okay. और ये उसी की साइड है. This is the scar. So जो endoscopic assisted है वो भी इतना scar मैंने देखा है. So I don't think being women you have the advantage के हाथ छोटे. So आपको शायद और it's easier to find it, but you can do it. और yeah, so that's it. Any questions? informative, full of words of wisdom. Any questions from the audience?
Yeah.
Yeah, so in your skin sparing, nipple sparing mastectomies, how do you tackle the terminal duct area? Do you always do frozen sections? Do you?
हाँ नहीं not always मगर ये कि हम जहाँ पे हमने T3 को डाउन स्टेज किया है या हमारा DCI उसमें हम ये है कि हम फ्रोजन सेक्शन करते हैं so उसमें हम फ्रोजन सेक्शन भेजते हैं to the retroareolar और retroareolar में भी थोड़ी सी डिस्क रखनी है वरना वो बैड होगा और उसकी वेस्कुलैरिटी भी खराब होगी मतलब ज़्यादा नहीं but you need about at least a centimeter to वो आपके पास टिश्यू और फिर उसकी जो टॉप है वो आप भेजते हैं फ्रोजन सेक्शन इसका एक और तरीका भी है पहले ज़माने में जब शुरू किया था मैंने की कि हम उसको पहले हम बायोप्सी करते थे before the procedure but that has changed now तो आप फ्रोजन सेक्शन करते हैं और अगर उसमें कोई DCIS नहीं है क्योंकि DCIS तो यूज़ करते हैं so वो फिर फ्रोजन सेक्शन and it is always you also tell the patient कि अगर हम जब ये करेंगे ये भी पार्ट ऑफ द कॉन्सेप्ट है कि जब हम करें और अगर निपल के उसमें कुछ आ गया बाद में तो वी विल जस्ट रिमूव द निपल सो दैट्स नॉट गोइंग टू बी हां वो नहीं है ना पर अगर कुछ आ गया तो आपको रिमूव कर सकते हैं
आपसे गाइड ही कर सकते हैं सारा
आपके जो डीप रेट्रोायलर चेंजेस होते हैं उनमें आपका क्या सो इट्स रेट्रोायलर व्हेन इट्स 2-3 सेंटीमीटर बिलो द
हां तो उसमें कोई फर्क
यू इजीली गो
और इसमें उसमें तो हम करेंगे तो सेंट्रल ट्यूमर में DCIS है डाउन स्टेज किया मैंने तो आई थिंक इट्स अ गुड आइडिया बट नॉट इन एवरीबॉडी बट जहाँ पे तीन चीजें होंगी तो जरूर क्योंकि DCIS में मल्टी सिंप्लिसिटी बहुत कॉमन है डाउन स्टेजिंग में आपको फॉल्स चीजें हो सकती है अगेन जैसे इफ यू रिमेंबर निपल डिस्चार्ज पे भी बात करनी चाहिए कि निपल डिस्चार्ज हो तो वो ऑल दोस थिंग्स नीड टू बी कंसीडर्ड के पहले सिचुएशन क्या थी ना क्या
So, I think frozen section को rule out करने के लिए use करना चाहिए. I had a situation when the pathologist said that there are atypical cells within the ducts. So I did not decide on table कि मैं nipple remove कर दूँ. And luckily जो उसके fixed sections हुए थे, it came back as LCIS, and we know that we don't have to revise margins or remove nipple on LCIS. So when it is negative, I take it and I don't use per-operative decision, especially if the pathologist is not telling us it's exact DCIS or not. Invasive, so obviously, we can say by the distance from the mammogram and ultrasound it's away. It's mostly about the DCIS. But because it is for the pathologist, it's very difficult to tell it is the DCIS or the LCIS without doing the epidural and stuff, the immunohistochemistry.
So, well, it's an easy fix as long as the patient is mentally prepared. आप तो local anesthesia और डाल के उसे पता होता है.
एक्चुअली स्टेजिंग अगर आपको प्लान यूजुअली होता है ऑन्कोलॉजिकल सर्जरी कर रहे हैं तो उसमें सीन पैनल कोई डिफरेंट करते हैं
नहीं इसलिए मैं एलडी वाली क्योंकि हम LVMF के कर रहे हैं. So मेरी एक्सिलरी क्रीज कि उसको जरा सा अगर ज़्यादा बड़ी ब्रेस्ट है आप जरा सा एक्सटेंड करने वाला हम वहीं से करते हैं सेटल की वजह से करते हैं ALMDs की हम करते हैं ALMD इज नॉट अ कॉन्ट्राइंडिकेशन बल्कि वो हम उसको निकाल के देते हैं अपने प्लास्टिक सर्जन को सारा कि देख लो कि फिर पंडित इस पे कल को हमारे सर में लगा दी कि क्या so वो हम उसी से तो इसीलिए
एक्सिलरी क्रीज आपका ज्यादा
मैं एक्सिलरी क्रीज से ही मगर अगर आपने इम्प्लांट करना है तो फिर इंफ्रामेमरी सबसे अच्छा है कॉस्मेटिकली और अगर आपको लगता है कि बहुत बड़ी ब्रेस्ट है तंग करेगी तो ये भी टेक्निक अच्छी रहेगी वो मॉडिफाइड बैक फ्लिप टाइप क्या जो है उसको
डॉक्टर आना फिर आप सेपरेट करती हैं जो मॉडिफाइड बैक एक्सिला
No, so I think in my modified batwing, if you guys, I mean, like those of us who do it, it really gives us a lot of space to reach all the way to the axilla and contra incisions axilla mein nahi. So I just do that single batwing and we reach the axilla through that. We do our ALMGs through that. और मुझे लगता है inframammary में that becomes a problem to reach all the way to the axilla and especially frozen positive आ जाए बस फिर तो you know it's
वो अलग so maybe देखें ना implant वाली ज़्यादातर risk reducing surgeries DCIS surgery so वो patient selection है जहाँ पे आप या BRCA positive पे operate कर रहे हैं वो वहाँ cosmetic concern ज़्यादा है आपको पता है कि आपने axilla
And then inframammary, I also don't like where I'm putting up nectar. Because when you have to make that pocket for the port, and that's where your incision is, then I'm just like a little bit not happy doing that. So inframammary is like actually not one of my favorites.
So implant के लिए again वही है कि direct to implant है कि आपने पहले expanded करना है, backend में वो population है, so मतलब वो सारे फिर implant के वो आ जाते हैं। मगर implants क्योंकि radiation है, they go very well, and patients have limited resources, so I prefer कि हम doing it. That's what.
Thank you so much, ma'am. Our next guest speaker is Dr. Amna Khan. She is highly experienced consultant surgical oncologist at Triple-Negative Hospital. She is providing comprehensive cancer care for many years. She holds an MBBS degree and MBBS in oncological surgery and brings over 20 years of clinical experience in surgical oncology. At Dr. Khanum, Dr. Amna manage a broad range of cancer area with a strong focus on evidence-based surgical treatment, breast cancer care, and advanced breast conservation surgery where feasible. Her work not only span operative management but also the patient advocacy, early detection strategies, and multidisciplinary collaboration in oncology. Thank you so much for coming.
Thank you so much for the kind introduction. Edward is home, so it's always wonderful to be back here. आप लोगों में से postgrad students, just so that I know the
All
audience.
our fellows of this surgery,
At house,
most of them are fellows.
Okay. Okay, so when I was looking at the program, I thought कि सबसे मुश्किल टॉपिक मुझे दिया है कि 10 मिनट में axilla पढ़ाते हैं. So अब 10 मिनट में axilla पता नहीं कैसे पढ़ेंगे. I'm going to try and be quick. We'll go over the big important things and we'll skip over the unimportant, controversial, sort of futuristic type things so that you know कि इस वक्त क्या हो रहा है, what's standard of care, with a little bit of an insight into what to expect in the future. So, why is the axilla important and why is it my favorite part of breast cancer surgery? It's because it's the single most important prognostic marker. It gives us the most adequate and the most accurate information about how to plan adjuvant treatment, and it's the most important marker for local regional disease control. So, मेरे हिसाब से जो कुछ axilla में हो रहा होता है presentation पे, and how the axilla responds chemotherapy के बाद downstaging पे is how your patient is going to eventually do. So more than the breast tumor, the axilla will tell you how the patient will fare. There's been a systematic de-escalation of breast surgery as well as axillary surgery as we have moved through the century. और अब जो most important चीज हम देख रहे हैं is the move to omit axillary surgery completely in selected patients. Axillary surgery की हम directly बात करते हैं. When we talk about it, we talk about a clinically positive axilla and a clinically negative axilla. And these are the two presentations जब एक patient आपके पास आता है. Clinically positive का मतलब कि examination पे nodes आप feel कर रहे हो, ultrasound पे pathologically enlarged nodes हैं. Clinically negative axilla makes the opposite. And the 4 different scenarios जो हम deal करते हैं is upfront versus post-neoadjuvant in a clinically positive and upfront and post-neoadjuvant in a clinically negative. और हम 2-2 मिनट में सब के ऊपर से skim करेंगे. So, what are the questions that we're addressing? We just spoke about that. We'll start with the clinically negative axilla. For those of us who are lucky enough to have patients very early stage, छोटे tumor T1, T2, examination पे आपको lymph nodes नहीं feel होते, शुक्र अल्हम्दुलिल्लाह, we send them for radiology and they tell us that on MR and ultrasound the lymph nodes seem to be normal. A lot becomes easy for the patient as well as for us when we're planning treatment on these patients. Clinically negative axilla में 2 scenarios हैं. एक bad biology tumor with a clinically negative axilla जिसको आपने chemo के लिए भेजना है, triple-negative HER2-positive. The other is your good biology tumor जिसमें आपने पहले surgery करनी है. So we're going to talk about that subset, your good biology tumor, clinically negative axilla, और हम उसको OR लेके जा रहे हैं surgery करने के लिए. अब क्या करें? पहले standard था axillary lymph node dissection, not true anymore. We do the sentinel node biopsy. It's been standard now for many decades, so I'm just going to skip over that. Now, what are the important trials of sentinel and where are we heading?
The two important questions are upfront surgery, clinically negative axilla में sentinel node अगर positive है तो ALND करने की ज़रूरत है. That question has been answered by the APSOG Z11 study. And we all know now that in good biology tumors, for T1, T2 disease, अगर breast conservation plan हो रही है, mastectomy में अभी proven नहीं है standard of care में. BCS में 2 lymph nodes, up to 2 lymph nodes positive, no EME के ऊपर, we can easily spare the rest of the axilla. So these are the results of the Z11 trial for local overall survival as well as local disease-free survival. The curves were very, very close, and we know that there is no difference. So इस patient subset में एक या दो lymph nodes अगर positive हो, EME नहीं है, तो ALND नहीं करनी. Third lymph node positive आ जाए या extranodal extension आपको pathologist बता रहे on your frozen section, then we go on to a completion ALND. That's sort of where we are with the Z11. The next question becomes, अगर हम full ALND नहीं करते, तो can we radiate these patients? So sentinel किया, positive आ जाता है, तो फिर उसको radiate करके हम ALND spare कर सकते हैं या नहीं? And that question was answered by the AMALOS trial के ALND की superiority है या नहीं? This was a non-inferiority study. This was the basic design. And again, the curves were very, very clear. So in AMALOS, if that is a recommendation that your institution is following, again, similarly, low burden axilla, sentinel node positive, clinically negative to start with, right? Never forget that. Unko radiation ke liye can be sent without any detriment to their prognosis. Okay, category number 2, clinically negative axilla, bad tumor biology, you send them for neoadjuvant chemotherapy, what needs to be done after that? We now know that what happens in bad prognosis tumors, जो neoadjuvant लेते हैं, our response to endocrine as well as chemotherapy is extremely, extremely good. And in case of clinically node negative status, the sustained node negativity again is a very, very good prognostic factor, which means that there is no progression of the tumor during your systemic treatment. There's 2 currently ongoing trials. They are prospectively looking at the omission of axillary surgery in the 2 subsets who respond really, really well to neoadjuvant treatment. And those 2 subsets are our triple-negative tumors and our HER2-positive tumors. The A6 trial and primary endpoint is 5-year axillary recurrence. And they're aiming to see that if you take neoadjuvant therapy in triple-negative and HER2-positive patients, clinically negative remains clinically negative post-systemic treatment, complete omission of surgery, sentinel B now is what they're proposing. And similarly, the European trial is also similarly designed. And the same question is being answered. If a clinically negative axilla remains negative, triple-negative HER2, just the response rate in the breast is as high as 50 to 70%, can we just leave the axilla and then do radiation? So, iska jawab hopefully in the future months hame mil jayega, but that is what we're looking at now. In our present day, we do sentinels, we prove that they're negative, and then we move on. And usually we've seen इस subset में it's extremely rare the clinically negative axilla sentinel पे post chemo positive निकला, almost never happens. Okay, now this is our most common scenario. जब patient हमारे पास आता है बड़े-बड़े lymph nodes palpable है axilla में, and this is our clinically node positive cancer patient. Axillary lymph node dissection is standard of care अगर हम upfront surgery करें. ठीक है, so this is that subset. Patients are not eligible to downstaging. There's some reason that you want to take the patient quickly for surgery, and we're doing high nodal burden axillary surgery in a patient who's clinically node positive. Some people are now recommending luminal A, luminal B tumors may, even if there's palpable nodes, upfront surgery does not have a problem in terms of survival. I have a problem with that. I normally upfront ALNDs बहुत कम करती हूँ, almost नहीं करती, but that's what has to be done. If your patient does not qualify, is high risk, heart disease, poor diabetic control, cannot tolerate chemo, and you have to absolutely do surgery, ALNP is the standard treatment. For low burden disease, this is where the fun starts. So low burden disease is when ultrasound paper or examination paper, all you see is maybe 1 or 2 or 3 zones that appear suspicious. And in these cases, for your good biology, luminal A, luminal B tumors, we can take them for upfront surgery. The options are wire localization of enlarged lymph nodes or clipping, so that when you do your surgery for the axilla, you can take out or identify these positive nodes and take them into your specimen as part of your axillary surgery, which is what we call tailored axillary surgery or targeted axillary surgery. TAG दोनों पे apply होता है. So इस scenario में patient comes, एक pathological node है या ultrasound पे है, आपने prove कर लिया FNA positive है, luminal A है, small t1, t2 tumor, आप upfront surgery decide कर लेते हैं. All of the positive nodes need to go with the sentinel node. And you need to be able to identify all of the positive nodes and take them out at the time of surgery and do frozen section. Because this patient subset may then have to go back to Z11 to make sure कि 3 से ज़्यादा lymph nodes positive नहीं है. So blue dye, radioactive tracer, localization of lymph nodes that were positive, all of that comes out in your tailored axillary surgery. And usually the sample of the lymph nodes is higher. क्योंकि इस केस में usually 4, 5, 6 lymph nodes sentinel के specimen में निकलते हैं because आप इतना कुछ निकालने की कोशिश कर रहे हैं. Now there's an ongoing Taxus trial which compares the tailored axillary surgery with or without axillary dissection followed by radiotherapy in clinically node positive breast cancer in both upfront settings and as well as the adjuvant settings. And we have seen that in the Taxus trial, again, वही पुरानी वाली जो मैं बात करी थी, that can this subset of patient targeted axillary dissection करके can you safely just send them for radiation therapy? Preliminary results seem to show that that is an acceptable option and it can be done. Okay, so management of axilla, clinically node positive patient, just go. Most frequently what we do is हम neoadjuvant के लिए भेजते हैं. अब node positive patient medical oncology में गया, neoadjuvant chemo complete की, 4 महीने के बाद हमारे पास वापस आ गया. इसमें 2 scenarios हो सकते हैं, या वो down stage होकर node negative हो जाएगा, या वो node positive ही रहेगा अगर इतना अच्छा response नहीं होता. So we'll tackle both of those scenarios separately. So axilla की management, if a patient remains clinically node okay, we'll talk about the node negative first. So best case scenario, you send them for chemo, they come back, अब lymph nodes palpable भी नहीं है, ultrasound के ऊपर feel भी नहीं हो रहा. This is an old trial, but it answered 2 very, very important questions for us. शुरू में जब हमने axilla की staging करनी शुरू की थी, तो हम sentinel node से करते थे. हम pre-chemotherapy sentinel node biopsy करके axilla stage करके medonc को भेजते थे, because at that time they wanted to know कि node positive disease है, क्योंकि उसमें AC taxol मिलता था, और node negative disease में सिर्फ AC मिलता था. So this is like the early 2000s. So the Sentinel trial answered 2 important questions for us. The first question it answered was कि एक ही मरीज के ऊपर 2 दफा sentinel biopsy is completely inaccurate. So if you do a sentinel, send them for chemo, come back, and the axilla looks okay, आजकल के scenario में you might leave it or do radiation therapy. In those days, they tried to see कि अच्छा repeat sentinel करेंगे, दिल नहीं चाह रहा axilla करने का, ख्याल है मरीज ठीक रहेगा, is that possible? So the Sentinel trial told us that false negative rates are as high as 50%, 2 times sentinel node biopsy नहीं हो सकती. Second tier nodes होते हैं, but it's not a very accurate way of staging the axilla if the prior surgery has been done. The second question that it answered was कि अगर sentinel node biopsy नहीं हुई थी, आपने de novo fresh patient systemic treatment के लिए भेजा है, can this patient come back and have an accurate sentinel node? And there was a lot of fight and debate in the early 2000s about this thing. कि कैसे पता चलेगा कौन सा lymph node positive है, कैसे पता चलेगा अगर complete response हो गया that you're taking out the accurate nodes or not. So what we traditionally talk about are 3 trials, and in the interest of time, I'll just go through this. The American College of Surgeons in the US, they did a trial, the Europeans did a trial, and then the Centena trial. And उसके अंदर उन्होंने different scenarios try किए कि this post-neoadjuvant patient, how do you accurately stage the axilla? कैसे sentinel node biopsy करें जिससे हमारा false negative rate कम से कम हो सके. And all these trials had complete ALNDs, so they're very well structured, very good trials. And if you kind of come down from top to bottom, you can see that what improved the accuracy and the false negative rate on these patients was firstly using a dual tracer, and secondly, the number of lymph nodes that were retrieved. So in some तीनों important trials की bottom line ये थी कि खाली blue dye और खाली radioactive traces से accurate sentinel biopsy post neoadjuvant नहीं हो सकती. Secondly, you have to have a minimum of 3 sentinel lymph nodes, preferably higher, to have an accurate staging. And thirdly, कि अगर शुरू में बहुत ज़्यादा disease नहीं है, तो pre-chemotherapy clipping of lymph nodes and retrieval of those जैसे हम targeted में कर रहे थे, वो करना ज़रूरी है. And उसके साथ the false negative rate acceptably falls to less than 5% in most institutions that do it routinely, and that is what the recommendation now has become. We prefer to clip lymph nodes if they are positive and not too bulky before sending them for chemo, and after they come back, we do a sentinel node, dual tracer, more than 3 retrieved, plus the clip lymph node retrieved. Okay. And then the easiest question. A node positive goes for chemo, comes back, is still node positive. And the recommendation is clear. Simple answer, level 1, level 2, level 3, only if there's suspicious pathology, kind of involved lymph nodes. Otherwise, level 3 is routinely not done. Recent advances, it's important to know that when we do frozen sections, I mean, all kinds of funny reports kabhi-kabhi milti hai. Sometimes the pathologist will say कि atypical cells nazar aa rahe hain. Sometimes the pathologist will say कि एक दो cells जो हैं वो lymphatic sinuses में नजर आ रहे हैं, लेकिन actually lymph node के structure के अंदर कुछ नहीं पड़ा हुआ. So it becomes very, very difficult frozen के report पे to decipher कि अब आपने इस patient की LND करनी है, या if you make a wrong decision, you'll have to bring the patient back to the OR in say 2 or 3 weeks time. So there's been studies and a lot of immunocytochemistry and then going back retrospective studies to see पहले हम isolated tumor cells के लिए या the floating cells and lymphatics के लिए ALND table पे कर देते थे because that is what was considered the safe thing to do to the patient. Now studies have shown that these floating isolated tumor cells or atypical cells do not translate into a bad prognostic outcome for the patient and probably are not node positive disease traditionally as we see it. So frozen पे अगर अब ITCs या ATPI उसके लिए ALND करने की ज़रूरत नहीं है because studies have proven that clinically that is irrelevant and insignificant. The other trials that we are kind of very closely looking at are to see if axillary radiation is non-inferior to axillary lymph node dissection in low burden axillary disease, pre-chemotherapy as well as post-chemotherapy. So the next 4 to 5 years will answer some very exciting questions, and I'm sure that we're going to move away from axillary surgery in a considerable number of patients. This we spoke about, and again, just to sum up, node negative disease, initially patient आपके पास आता है, so we do the sentinel node, and then we don't do ALND in 1 or 2 positive lymph node patients. Similarly, if these patients go for chemotherapy, when they come back, sentinel node biopsy is done. In the next 5 years, may not be done if a patient remains clinically node negative. Similarly, node positive disease, answer, simple question, node positive goes to chemo, comes back, node positive ALND, comes back, node negative, then we do the sentinel node biopsy, dual tracer, more than 3 lymph nodes, clip lymph nodes come up. And that's it.
मैंने इतना अच्छा बता दिया है कि कुछ छोड़ा ही नहीं उन्होंने पूछने के लिए।
अगर करें कि याद रह जाए मोटी-मोटी चीजें एग्जाम एक्सेलर कवर हो जाएगा
मैडम करंटली आप कोई ट्रायल अभी एक्सेलर से रिलेटेड जैसे पहले तो हम कर ही रहे थे एमरॉन्स की लेवल की अभी करंटली आर यू रिक्रूटिंग सम
So Shaukat Khanna, we are not part of any axillary trial as such. touch. There's like 1 or 2 UK trials with upfront ALNDs that they've become a part of, which I'm not really happy with because N1, N2 disease upfront को जब आप axilla dissect करते हो, level 3 ALNDs कर रहे हैं, those patients are getting late to go to systemic treatment. I'm a big advocate of neoadjuvant downstaging, hormonal, chemotherapy, targeted therapy. मेरा बस चले तो मेरा कोई मरीज upfront surgery के लिए नहीं जाए with a node positive disease because I feel that systemic treatment is what has the biggest impact on your survival. And if you're delaying systemic treatment by doing big axillary dissections, we're all surgeons, we can do the axilla. उसमें कोई heroic नहीं है. But drain अंदर ज़्यादा दे रहता है. 2-3 हफ्ते के बाद seromas बन रहे हैं, aspirations हो रही हैं, and patient की systemic treatment delay हो रही है. So then you're not really doing the patient a big service. It's okay. Preliminary studies may show कि उसमें survival advantage नहीं है, but I think the morbidity is higher for the patient. Locally, the patient does not do well if there's extensive axillary dissection, and I really believe that we do a service to the patient by downstaging the axilla before we do it. The only trial that we're doing actually these days is something interesting, जो हम prospectively देख रहे हैं कि intercosturatal nerve को save करने का फायदा है या नहीं. So we're randomizing patients to sacrificing the intercosturatal versus saving it. And the preliminary data shows that patient key satisfaction or morbidity पे बहुत फर्क पड़ता है. If you take that extra 10 minutes and save the intercosturatal. But that's the only auxiliary trial that Shopper is. Yes.
upper limit है उसपे टिप जरूर रखें आजकल रेडिएशन के लिए बिकॉज वो सीटी प्लानिंग जब करते हैं तो वो एक नोट्स को लेवल 3 नोट्स को डाइसेक्ट करना है जो आपकी अपर लिमिट है एक्सिलरी डाइसेक्शन उसको टिप जरूर रखें
मैडम ड्यूरिंग सर्जरी
So जैसे आप lumpectomy में clips छोड़ते हैं for radiation, every DCS requires clips for radiotherapy guidance. इसी तरह traditionally we were taught to leave a clip at the highest dissected lymph node. वो level 2 है या level 3 है, but जो भी ILND आप कर रहे हो, the highest level that you remove, just put 1 or 2 clips so that the radiation people know how high you are.
That's of course using the clips for hemostasis anyway.
If you're using the clips for hemostasis, that's fine. But if you're using, for example, the endoscope, the ligand shore up use कर रहे हैं या harmonic use कर रहे हैं, तो उसमें clips कम use होते हैं. But just remember कि कोई marker, कोई footprint होना चाहिए how high you went in cancer. So just make it a point to leave a clip अगर harmonic use हो रहा है या अगर कोई और device use.
You have a patient who is seeing metastatic and she's scared for having what do you do with the axilla? Traditionally, it's prognostic, right? So there's really no point in doing the thing. But if there is disease in the axilla, would you remove it? Would you leave it? Where do you stand on that?
So that's a really good question. I think it's important to see what morbidity your surgery will do on a metastatic patient. क्योंकि हमारा सारा premise of surgery change हो जाता है जब stage 4 patient आता है. So I think if there's disease in the axilla, which is say gross disease, palpable disease, but will not have an impact on the morbidity of the patient, if you remove it, then go ahead and do that. लेकिन बड़े-बड़े chunky level 3 lymph nodes को heroics करके निकालना, I really don't believe in like cowboy surgery of that sort because that will add to the morbidity of the patient, and that is not really being of a service to the patient. So for stage 4 metastatic disease, I take out axillary disease, which is safe and will not add to the morbidity. Or अगर bulky nodes level 3 में हैं, to just leave them because our intent is palliation. And you have to remember that everything that can come out should not come out if it's not going to help.
If you take in an upfront setting, if you have done a dual tracer sentinel lymph node biopsy and it is only one lymph node that has been localized and that is positive, just one out of one is positive, would you go on table to decide go for further axillary clearance or will you
So that's a very interesting question because we're a little bit in a dilemma. जब हमारी yield of sentinels इतनी नहीं होती. You know, what if it's only one node? What if it's only 2 nodes? 2 of 2 positive आ जाए तो वो और मुसीबत. But the point of the matter is that if you're sticking to a guideline and you believe that a certain, guideline is true. So then, if there's no extranodal extension and your size of the metastatic deposit is, under a centimeter, and the patient is luminal A and there's no other risk factors, then, just hold your hand and then there is no ALND, even if 2 of 2 positive, because that's what the guideline has kind of proven to us. And if you're following, then you need to follow wholeheartedly.
So we proceed with radiotherapy in that patient.
2 of 2 positive में पहले systemic treatment होती है, because these patients will most definitely have full systemic treatment followed by radiation.
Thank you so much, madam. Our next guest speaker is Dr. Iram Najib. She is a consultant breast surgeon based in Islamabad with MBBS, SCPS, MRCS, FRCS, and fellowship in breast surgery. With over a decades of experience, she combined surgical oncology with oncoplastic principle in breast cancer care and reconstruction. She also served in academic role engaged in breast cancer awareness initiative through leadership in tertiary care center like PIMS. Currently, she is working in Shifa International. Her expertise brings surgical treatment with patient education and early diagnosis strategies. Madam is going to discuss the level 1 plastic breast surgery level 1.
Thank you very much. So I'm going to cover the level 1 oncoplastic surgery after having heard the excellent talks by senior colleagues. My other colleague is going to cover the level 2 oncoplastic so that there is continuity of what we are talking about. So oncoplastic surgery, as we all say it again and again, is a blend of art, which is the plastic part, and the science, which is the oncological section part. Why it is important? Because traditionally, you can see this picture explains it all. How does women used to live after their breast cancer surgery? So the first picture you can see literally a huge hole in the chest wall, followed by we moved on to the modified radical mastectomy, leaving the pec major and pec minor behind, and then what used to be called as breast conservation surgery was actually a deformed mound of breast that the patient was forced to live with. And then we are moving to oncoplastic surgery, where we are trying to be oncologically safe first and foremost, and then if we can do a little extra peroperative changes which can give a patient better cosmetic outcome, so that obviously after every cancer treatment, the aim is that we have to give the patient life that as close as to the life that she was living before cancer treatment. So there is huge talk on quality of life post treatment and rehabilitation, and breast aesthetics is an important part of that rehabilitation. We should not tell that whatever we have made, मैं पेशेंट को कहती हूँ कि the breast should look like a breast after a breast conservation surgery. So the benefits of oncoplastic surgery over conventional, it is fourfold. We are able to do wider margin resection when it is needed, and smaller breasts which were due to high breast to tumor ratio, they were getting mastectomies. With level 2 oncoplastic techniques like replacement techniques, we are able to save smaller breasts now as well. And obviously it has better aesthetic outcomes, and most importantly, it has a lot of meta-analysis and researchers have shown that it has acceptable local regional recurrence rates as well. So just a little comparison of quadrant by quadrant. If we go, if we do a conventional breast conservation surgery, so medium-sized breast, having had removed anyways, so you can see at 6 o'clock they've probably removed a tumor at 6 o'clock, and this is a typical bird beak deformity. There was no attention placed to the fact that if you remove without glandular displacement, there will be a big gap in the gland, and with passage of time, the nipple has actually retracted towards the BCS cavity. Obviously, with if the tumor to breast ratio is high, you can go to the level 2 oncoplastic techniques. And this is a patient of mine where we have tried to conserve a smaller breast. Even in an acre breast, a 2 centimeter tumor is going to be, something that can leave a dent behind. So you have to think that probably either if the patient is a candidate for neoadjuvant chemotherapy, send the patient for downsizing. If not, if the patient is candidate for upfront surgery, you can always do level 2 oncoplastic techniques. Another problem with huge topic breasts. Although the breast is huge, that does not mean that you can remove any sort of tumor from any quadrant. You have to make sure what is the position of the nipple, how taut the breast is, and again, which quadrant you are removing the tumor from. So a typical deformity in the upper outer quadrant, although the upper outer quadrant is the most forgiving of the quadrants, but still, if you don't place enough attention, you can make deformities like this, and this can easily be rectified if you again do this sort of surgery, if the patient is a candidate for it, and if the patient agrees to have a little smaller breast than the contralateral and agrees to have a symmetrizing surgery either at the same time or staged procedure. So level 2 wide span reduction mammoplasty can solve this issue. Another same picture, and a J mammoplasty has been done for the comparison. So local recurrence and oncological outcomes, I have talked about it already. There is no difference between the oncoplastic breast surgery and control arms, including breast conservation surgery and mastectomy. And there is better, some studies have even shown that there is better recurrence rate, and probably because of the fact that breast conservation surgery is basically done in good biology tumors and early stage breast cancer. So coming to the types of oncoplastic technique, I'm going to just cover the volume displacement ones, which will be the other way around. So the level 1 oncoplastic techniques. So level 1 oncoplastic techniques are given to the patient when we think that the volume, expected volume resection is less than 20%. So you can think that 1/5, if you think of breast to be a circular shaped structure, and 25% would be exactly one quadrant, a little less than would be 1/5. So if you are suspecting that you will be removing less than 1/5, then you can easily use level 1 oncoplastic techniques. It's a dual plane undermining, including the nipple areola complex, and we always pay attention to the re-centralization of the nipple areola complex if it's needed. So almost all of these level 1 oncoplastic techniques involve re-centralization of the nipple areola complex. That's because of I have shown you the deformities. If you place an incision much away from the nipple areola complex and do resection underneath it, and you, with passage of time, the nipple would be retracted because of the scar fibrosis towards that scar. So this is the list of the common level 1 oncoplastic techniques that we use: lateral mammoplasty, JAV, batch vein crescent, and the round block mammoplasty. I'm going to show you the picture by picture the description again later on. So how do we select which patients are going to go for level 1 and for level 2? There are 3 factors. One is the patient factor, one is the disease factor, and one is the surgeon-related factor, obviously. So patient-related factors, obviously, you have to see how early, what is the size of the tumor, if the patient is going for upfront surgery, can the patient be downsized and downstage with neoadjuvant chemotherapy, whether previous radiotherapy has been given to the chest wall or not. Again, it's a little controversial that we do not do breast conservation surgery on a breast that has already had radiotherapy, just because obviously we cannot give radiotherapy once again. Familial and genetic risk factors, obviously you have to think if the patient has a BRCA gene positive giving a breast conservation surgery would have an unacceptably high recurrence rate. So you have to counsel the patient whether they are going for a mastectomy or a breast conservation surgery. And then the comorbidities, drug history is very important, whether the patient is on immunosuppressants, anticoagulants, and smoking history, especially important when you are considering the chest wall perforative flaps and the level 2 oncoplastic techniques. So, oncological factors, the number of tumors. So, one of the controversial areas where we are pushing boundaries with oncoplastic techniques is the multifocal and the multicentric tumors. Traditionally, it used to be thought that multifocality or multicentricity is a contraindication to oncoplastic breast surgery, but not anymore. Especially if the multicentric tumors are close to each other, and you can easily plan a resection where you can remove both the tumors and still conserve the breast. I'm sure Dr. Sarah is going to talk on it when we are using level 2 oncoplastic techniques. Location obviously is important because your technique is depending on where the tumor is actually lying. Extent of the planned skin resection. Normally, traditionally we used to be taught that you have to remove the skin overlying the tumor, but not anymore. You do remove a little bit of skin for the nipple recentralization, but that is a planned resection, not something needed for oncological resection. Neoadjuvant systemic therapy may benefit patients by reducing requirements for mastectomy, oncoplastic breast surgery complication. So always consider neoadjuvant chemotherapy, even if you know a fancy level 2 oncoplastic technique. If for a bigger tumor, it's better if the patient can be downsized, and if the level of oncoplastic technique can go from level 2 to level 1, that's good. So safety comes first. Technical factors to consider, obviously, the BRCA size and the doses is important. What is the notch to nipple distance, especially in the wide pattern reductions? Is there any previous mammoplasty that has been done for example, for cosmetic reasons? What is the nipple sensation? Because most of these mammoplasties will reduce the sensation of the nipples, and then you have to counsel the patient according to that. And if there is any pre-existing chest wall asymmetry, what is the quality of skin? It is very important because especially for level 2 techniques, if you are moving too much tissue from here and there, the skin quality is important, and especially with fat necrosis can happen after extensive mobilization of the gland. Then you have to obviously review the radiology. If it is unifocal, is there any associated microcalcifications that needs to be removed? Most of the patients, even if you diagnose a patient with cancer who are less than 40 years, you have to get a mammogram because you have to see if there is any associated microcalcifications or not. And you don't need to just remove the tip of the iceberg, you have to remove the associated or impalpable tumors as well. And if there are any, you have to localize them in an appropriate way, just like Dr. Upina Sumro said, and you have to include it in your resection. Records from previous surgery, especially very much applicable in our part of the world where patients are getting lumpectomies with involved margins without having a prior true cut biopsy. It is very important to have any records of the previous surgery. So just to summarize, which technique to use depends on the extent of the section. What is the expected residual breast tissue? Position of the tumor? What is the expectation of the patient? Maybe your patient is not interested in a fancy wise pattern reduction mammoplasty. You may be able to do it, but the patient does not want any kind of extensive surgery. They do not want a contralateral symmetrizing surgery. So you may be better off giving them just the level 1 oncoplastic breast surgery. And one of the most important thing is that you have to, so where the tumor is, our dissection planes go beyond it, because obviously you are recruiting the breast tissue towards the cavity so that you can do a tension-free closure of the lumpectomy cavity. So quadrant-wise distribution of the techniques, you can see for upper quadrants, round block, batchwing works really well. For the lateral mammoplasty, the lower outer quadrant, that's the J mammoplasty. So they are all variation of almost the same procedure. If you can use natural freezes like the lateral, like the inframemory fold, the periolar, where the scars heal really well, or the axillary skin freeze, you should be using those. So after an incision, what you do is go in the mastectomy plane, mobilize skin and the subcutaneous tissue, mobilize the gland. If nipple areola undermining is needed, you do that. You remove your lumpectomy, the tissue excision from the subcutaneous tissue down to the pectoral fascia. If the pectoral fascia is involved, obviously you remove along with your lumpectomy. You place clips on the lumpectomy bed. Then reapproximation of glandular tissue is very important. Pay attention to especially ladies who are older because their breast is not very well vascularized, mostly fatty, and fatty tissue does not take stitches very well. And also, if you mobilize too much to do oncoplasty, then you will undergo fat necrosis. It's going to take ages to heal, and it leaves hard tissue behind. Then deepilization and repositioning of the nipple areola complex. So let's do a few procedures with diagrammatic representation. So this is a round block mammoplasty where you place two incisions in the circumareolar position. The width of this depends on how much you want to reduce the envelope of the breast. You do the lumpectomy, reapproximate the gland, and at the end, all that is left is a circumareolar incision. This bit you have already deepilized, so this is stitched. This circumareolar complex is stitched to the outer ring. So this is your round block mammoplasty. Works really well in the upper half of the breast, the 12 o'clock, the upper outer, and the upper inner as well. Just one of my patients. So batwing mammoplasty again works really well when you are planning to do it's in the upper central of the breast, the tumor, and the skin is pretty close, and you want to remove a little bit of skin, give a little process to the lift to the breast as well. So this is essentially looks like a bat wing. So that's where the name is coming from. You do the resection, you have to remove the skin if it is needed, and then it's closed with two little wings at the end. One of the patients having a bat wing mammoplasty, and you can see there is hardly any visible difference apart from a little lift that is inherent in a bat wing mammoplasty. Last, this is something that I use especially when I'm removing central quadrants and the patient is older or they don't want too much fancy techniques. So this is a central quadrantectomy with first ring closure. Some of the surgeons may not like it, especially my colleagues when I was working with them and I was getting trained in the UK. They didn't like it, but I started using it in Pakistan. It really heals really well and leaves a little bit of mound at the end, which appears to be like a nipple if you do it correctly. So essentially what you do works really well in base disease of the breast as well in retroareolar tumors when you cannot save the nipple areolar complex. You essentially do your central quadrantectomy, remove the central quadrant, and you do a 2-layer of first ring closure. And this is what's left behind. It heals really well. This patient of mine has gotten a first ring closure. Another one like this. So lateral mammoplasty incision, almost same kind of incision. Apart from that, two circumareolar incision and there is a lateral wing to it, and that's why we call it as a lateral mammoplasty. Crescent mammoplasty is done when the tumor is close to the areolar edge and the skin is close as well. So you essentially remove a crescent of tissue and close it. One of the simplest of all mammoplasties. So just a little comparison of between level 1 and level 2. Obviously the level 1 techniques are simpler techniques. and level 2 are much more complex techniques. Symmetry is generally better in level 1. In level 2, obviously, you have to sometimes symmetrize the opposite side as well. Problems, perioral inverted T, especially the T junction problems with wise pattern and vertical scar mamoplasty, because that is the area which is taking all the weight of the breast. Sometimes it can have, it might be a very small area where it takes ages to heal, and it can delay patients' radiotherapy as well. So you have to know the inherent problems with level 2 oncoplastic techniques and select your patients very carefully. Obviously, level 2 oncoplastic techniques are much more complex, so the theater time needed is important, especially if you are working in a setup where almost everywhere it is important, but especially when you are pushed to do a lot of patients in one day. The healing time obviously is much more in the level 2 oncoplastic techniques, because the donor site has to heal, especially if you are doing the chest wall perforator flaps. Mammographic surveillance. So this is a little area where I personally had a problem with one of the patients. Obviously, there is how should I say it? So when the flap is inside the lumpectomy cavity, it may give some shadows to the radiologist where they get worried maybe it's a recurrence. I recently had an experience with one of the radiologists, and I think few weeks after the surgery, they were told that there is something inside, and so you have to educate your radiologist where you are working as well. And I have to tell them that it's the flap that we have taken from the side. It is inside. It's not the tumor. We have already taken the tumor out. And in a place like Pakistan, patients are already on the edge to, blame you for everything that you have to do. So that's why patient selection is very important. You have to educate the patient that this is exactly what you are doing, and you have to educate, especially when you're doing complex procedures like this, you have to educate your radiologists as well, and the oncologists as well. Unfortunately. So sometimes they will tell you, why did you do this procedure for such a small tumor? They think that all the chest wall, all flaps are probably like LD flaps. So that is very important because obviously all of us are not working in a private tertiary care hospitals where everybody is on the same page. So it's important for us, the onus is on us to educate all of them. So take home message, oncoplastic techniques have a learning curve, so always start with simpler procedures. Never compromise patients' oncology for plastic, which is aesthetics. Yes, aesthetics are important, but oncology takes the lead, and hence the name oncoplasty is not oncology. So more than one technique may be applicable for a given patient with this same kind of tumor, but you have to always keep the patient safe, keep the patient's wishes in mind. You have to spend time with them, sit with them, what they want, expectations and post-op recovery in mind. So usually if done properly, patients like their newer breast better after oncoplastic surgery than the older one. And they may request you to do the other side as well. Thank you very much. If there are any questions, I'm happy to take them.
My favorite oncology statement is, patient is not fit for chemo. Please do surgery and treat with chemo. Very common. Hello. If she's answering now, how she was.
Thank you so much, madam. Our next guest speaker is Dr. Sarah Salim. She is unable to come in person, so her recording lecture is with us. She is head of Department of Breast Surgery in Medina Teaching Hospital and Professor of Surgery at UMDC. She holds MBBS, FCPS, MRCS, FBPS. I'm reading these, I have a study for it, but here we are. Making her one of the most internationally qualified breast surgeons.
Good morning, everyone. I'm grateful to the organizers and audience sitting here. My today's topic of presentation is level 2 oncoplastic breast surgery and alternative to mastectomy. And key points of my today's presentation will be to highlight the practical aspects of oncoplastic breast surgery. The modern breast surgery has evolved from the hosted mastectomy and then the modified radical mastectomy and then breast conservation and then oncoplastic breast surgery. And now treatment is more individualized. It is based on individual tumor characteristics like stage of breast cancer, its location, its biology, and the patient characteristics like breast size. Each patient has different breast size, its shape, its ptosis, and many other factors. So now, through the years, oncoplastic breast surgery has enabled surgeons to remove greater volume of tissue successfully and thus reducing the mastectomy rates. So, but why breast conserving surgery is uncommon in Pakistan? There are patient-related factors. Many women opt for mastectomy due to limited awareness. There are cultural taboos, financial constraints, or the misconception that removing the entire breast guarantees better survival. Some decline breast reconstruction after mastectomy due to the expense or fear of complications. And then we see surgeons-related factors. There are limited surgeons who are trained in advanced oncoplastic breast surgical skills in Pakistan, and it is a very important factor that contributes to low adoption of oncoplastic surgical skills. So what do you think? Which of the two is a major factor that this skill is not very commonly utilized in offering breast surgery to patients? I think the second factor is more important because the surgeon can guide the patients and do an effective counseling for breast conservation if it is really indicated. So the oncoplastic breast surgery is a blend of art and science. Onco means cancer and plastic means aesthetics. The goal is to combine the best possible cancer outcome with the best possible cosmetic outcome, visualizing for each woman in her wishes, and the goal is to help the woman to feel whole again as a part of her cancer journey. So, oncoplastic procedure guide, how we can choose between level 1 and level 2 oncoplastic breast surgery. There is a criteria, although it is arbitrary. One of the factors is maximum CN volume ratio. If you want to size less than 20% of the volume, then level 1 is the better choice. If we want to size more than 20% up to 50%, then opt for level 2, but it is not the only criteria. We also see how much is the requirement of skin excision for reshaping. Usually in level 1, there is not much requirement for skin excision. Only make an elliptical incision and do some undermining and then approximate. But in level 2, yes, there is a requirement for we choose a certain pattern of skin incision and then we do excision, and I will explain it in the upcoming slides. Then lemoplasty, yes, it is not a requirement for level 1 oncoplastic, but it is a requirement for level 2 oncoplastic surgery. Then granular characteristics. If the breast is dense, then we can opt for level 1 oncoplasty. However, if it is dense or fatty, then level 2 oncoplastic surgery can be opted. So, what this image is showing, it is showing a mammogram. It is very important for an oncoplastic breast surgeon to have a look at the mammograms to exactly see where the tumor is located, how much it is away from the skin, from the underlying pectoralis major muscle, about the surrounding microcalcification. So this must be displayed in the operation theatre. Regarding breast density and plane mobilization, undermining the breast from both the skin and pectoralis major muscle, that is the dual plane undermining, is a major requirement for level 1 oncoplastic breast surgery. A dense glandular breast, that is ACR category C or D, can easily be mobilized by dual plane undermining without the risk of necrosis. However, if there is no density of breast and there is more fatty tissue, ACR A or B category, it has a high risk for fat necrosis after extensive undermining. So, level 2 oncoplastic is a better choice in this case. Regarding volume displacement or volume replacement technique, level 2 oncoplasty, we can utilize a volume displacement technique, or if we use a local flap, we call it a volume replacement technique. So it is differently indicated depending on tumor to breast size ratio, tumor location, and breast morphology. The predicted percentage of resected breast tissue represents the main factor who requires one of the two techniques between 20 to 30% to do a volume displacement, and it also depends on the breast size. If the breast is of adequate size, like D cup or more, you can easily do a volume displacement technique. And contrary to that, if the patient breast size is small, like A cup, B cup, or C cup, and we don't need contralateral breast symmetrization, then we usually would choose a volume replacement technique. With respect to volume replacement technique, the introduction of facial tennis flaps allow minimizing donor site morbidity and generally without the need of symmetrization of the contralateral breast. So regarding level 2 oncoplastic breast surgery, if the tumor is located in the lower quadrant, like at 6 o'clock or 5 or 7 o'clock, we can use a vertical pattern mammoplasty as shown in this picture. This is the vertical mammoplasty, and this lower picture is showing an inverted T mammoplasty. So in the vertical mammoplasty, it's a very popular technique because of a lot of benefits. The first picture is showing this a dome-shaped incision for the areola, then two curvilinear vertical incisions, and if the tumor is located anywhere at 6 o'clock or at 12 o'clock or just on the sides, we can approach the tumor through this approach. And the second picture is clearly showing this pedicle. It's a supromedial pedicle used for nipple and areola complex. So a very important thing is that the skin pattern is different from choosing a pedicle. The pedicle is selected according to tumor location. Usually, if the tumor is at 6 o'clock, we choose a superior pedicle, supromedial or medial pedicle. But if it is located at 12 o'clock, inferior pedicle will be a better choice. This picture is showing a voice pattern mammoplasty. It looks more complex to the initial career surgeons, but it has its own utility, especially when patient has a large protein breast and in certain locations of the tumor, then voice pattern mammoplasty is a very good option. This picture is showing its marking from sternal nose to nipple, but now the oncoplastic surgeons are more in favor of using breast print, this upper marking of breast footprint. Usually the future nipple is marked 8 to 10 centimeter from the footprint of the breast. This picture is one of my patients in which voice pattern mammoplasty was done, and you can see the markings, sternal nostril distance, that is kept at 20 centimeter, then vertical pillars, and then the horizontal markings. Another patient, this is one of my very recent patients, in which the radiologist has marked the hip. At this location, the cross is marked, but patient was insisting that her tumor was located here. So I will have to choose an option where I can easily approach at both of these sides. So voice pattern, inferior pedicle voice pattern mammoplasty was utilized, and you can see this was the, and during intraoperatively we saw that patient was right. So you can see a very good prosthesis after doing the inferior pedicle voice pattern mammoplasty. The right side was operated by my resident, and it has good results. Another thing we should not keep breast size so small, like C cup or D cup. We have to look into patient's general body habitus as well. Half of her abdomen is covered by her trouser. She was of high BMI. So the breast to body ratio should also be considered while doing markings. One of my patients that I operated 9 years ago, vertical oncoplastic was done. So central breast tumors have long been, these tumors were refused for opting the breast conservation surgery, and mastectomy was considered the safe and better option, but now we can offer breast conservation even in central breast tumor, as shown in this picture. In this resortive flap used after doing a central quadrantectomy, and this patient and another patient having Paget's disease, we have done a central quadrantectomy and reconstructed using a resortive flap. Another elderly lady, she was very keen for breast conservation, and central breast tumor and resortive flap was used for reconstruction. And this picture is showing a modified all-Findlay technique, again for central breast tumor. And here I would like to share Elizabeth Hall-Findlay. She is one of the pioneers of oncoplastic breast surgery, and I will recommend her this article published in 2024-25 about breast reduction, what I have changed over the years. It's a very interesting article, and Hall-Findlay, she has described how she learned from her mistakes, and that has reshaped her skills. And it's very important that we refine our skills, especially the early career oncoplastic surgeons must read this article. Very important, she has shared very important tips, especially what mistakes she committed in her early surgeries. Another patient, so if the tumor is of large size and it is extending beyond nipple and areola complex, and there is less place available for resorting, we can use a bispecific oncoplasty technique, and still we can conserve the breast, and still we can avoid mastectomy. Now I will describe volume replacement techniques. These have progressed over time, expanding the oncoplastic reconstructive arsenal from use of pedicle lattice glossy muscular tennis flap to use of several facial tennis flaps available in the thoracic region. So there are various chest wall perforated flaps available. We can use like thoracodorsal artery perforated flap, lichen flap, and then L-type flap, an anterior intercostal artery perforated flap, and medial intercostal artery perforated flap. TDAP flap, it is designed like LD flap, but usually we make insignificant 1 to 2 centimeter in front of the LD marking, because the perforated is lined 1 to 2 centimeter in front of the main vessel, as shown in this picture. So this is a picture of one of my patients in which lichen flap was reconstructed. This is the dissected perforated, and this is the final result after doing a quadrantectomy and insert of lichen flaps technique. This is one of my patients. As a breast surgeon, everyone of us faces such cases in which inadequate surgery is done with incomplete initial workup, and the lumpectomy is done considering that a 30-year-old patient having a small lump will have benign lump. So total biopsy is not done and simply lumpectomy is done. So this patient came to me and her imaging was showing a residual tumor there. So in this patient also, this whole quadrant was excised. After doing the quadrantectomy, lichen flap reconstruction was done. So this picture is showing dissection scar that is usually done under garments. Another case, this case I performed live demonstration at Triple-Negative Hospital. You can see the patient has had a T4B lesion. So we have to replace this area of skin as well. So as compared to previous case in which the overlying skin was kept intact, in this case we have used a patch of skin to cover this tumor area. And this picture is showing the marking of live flap. Another patient in which ICAP flaps was used. You can see the tumor at 5 and 6 o'clock position, and this is the cavity after resection of the tumor. This is the inside of ICAP flap, and you can see a very good fine scar after completion of the surgery. Good concealed scar. So I think if there is some time, you can see the review of lichen flap that was performed at Najina Hospital.
If anyone have a question, we are expert panelists here. Dr. Sara की से related कुछ प्रश्न है? Our last speaker is Dr. Professor Ahmed Qureshi, who is the head of Department of Breast Surgery Unit and a highly respectful leader in the field of breast surgery. He is not only our student surgeon, but also exceptional.
Thank you so much. First of all, I need to thank all the worthy guests and the participants who have been coming to the most of the workshop that we do. And specifically, I would like to thank again Dr. Amna, Dr. Uma, Dr. Iram, Dr. Professor Musessan, and Professor Freedom to should be in record that it was the first course that we did on breast surgery, oncoplastic. That was a brainchild of Professor Freedom. So sir ne bulaya aur dikhaya, and it was the peak of COVID, and I thought कि कोई भी नहीं आएगा इस टाइम पे, पर लेकिन सर ने कहा कि तुम बनाओ, and we made something, and I'm very thankful to Dr. Amna, Dr. Huma, Professor Musessan. ये तो पहले दिन से लोग कोर्सेज कर रहे हैं, that is 2019 actually. So peak of COVID में पहला मेरा कोर्स है. Thank you very much sir, and thank you very much. So back to this course, we were just wanted to how can we make it more interactive. जो lectures मैंने सुने उनके बीच में I learned a lot new technologies और नई चीजें जिससे definitely, and I think this is how we can actually make a small media book. जो उसको पढ़ सकते हैं अपडेट्स के हिसाब से यूज कर सकते हैं, तो we'll ask the senior members. So I thought we should start with the something different. So is there a role of robotics? So in breast surgery, probably not. So this is the first thing I got in my mind. Very recently I found a very interesting workshop in Sharjah, and it was actually an online course, and the actual surgeries were telecasted from Yonsai in South Korea. So then I started looking at क्या robotics का कितना role है. So it's a very brilliant किस्म की होगी. I'm sorry if अगर coherence में problem आ रही है, because so I thought all the breast surgeons need to know about the robots. So with the passage time, they need how to do it. So just starting with the robot is a reprogrammable multifunctional manipulator designed to move materials, parts, tools, or specialized devices through various program motions for the performance of a variety of tasks. This is just in 1979. So there was no definition for a robot before 1979. So और consensus statement जो सी है वो breast surgery के मुताबिक symposium में 2019 में आई, जिसके ऊपर उन्होंने कहा कि जी robot assisted mastectomy first performed in 2015, right, only 10 years ago in Milan, and then the center stopped doing this. So उन्होंने कहा कि नहीं ये ठीक नहीं. But anyways, and uske baad there have been several case reports and case series on these, and the described technique used both gas or gasless insufflation, and most of the cases involved immediate implant reconstruction. One randomized control trial is only one randomized control trial to date is being done is on to 80 patients being randomized, and the robotic procedure was done has a longer duration of 60 to 80 minutes as compared to the open technique. So, but it decreases the nipple areolar complex necrosis, and mastectomy thin flap necrosis is also less as compared to the traditional nipple sparing mastectomy. And combined with the subcutaneous और प्री पेक्टोरल acellular donor matrix ये इसके साथ कंपेयर करके दोनों को मिक्स कर सकते हैं. So this article also said that the robotic harvest of the deep inferior epigastric flap, pedicle and lexismi dorsi flap is safe and decreases the donor side mobility. Plastic surgeons can tell us more about this. The robotic microanastomosis in autologous breast reconstruction and the lymphedema surgery may provide improved precision through motion scaling. Motion scaling क्या है, tremor elimination क्या है, improved ergonomics क्या है, ये अभी थोड़ी देर में आपको बताता हूँ. But these are the three things that robots help you करने के लिए. So just quickly we need to know कि इस पूरी दुनिया में कौन-कौन से robots के console available हैं, जिसके बीच में they all have these areas that you need to consider. The precision of the dissection है, ergonomics है, surgeon fatigability कम हो जाती है, multi quadrant की access है, and cost of workflow efficiency important होती है. 5 सिस्टम इस टाइम पे दुनिया में बड़े काम कर रहे हैं, बाकी पाइपलाइंस में है. डा-विंची सिस्टम है, वर्सियस है, सेनहॉस है, और हुगो रास और रिगो है. सो वेरी क्विकली स्मॉल डिस्क्रिप्शन. ये पहली वीडियो आप जो देख रहे हैं ये है डा-विंची सिस्टम की. डा-विंची सिस्टम इस टाइम पे is the patent that started, and it started why because प्रोग्राम ये था कि मार्स के ऊपर और स्पेस स्टेशन के ऊपर ऑपरेशन करना पड़ेगा, तो ये सिस्टम से करेंगे, but it didn't work that way. So उसके बाद 2020 से इसका पेटेंट खत्म हुआ. So they have changed the models a lot. अभी भी स्पेसशिप ही लगती है, लेकिन it gives you a 360 degrees of motions. It has 7 degrees of freedom. What does degrees of freedom means? कि एक x axis है, एक y axis है, एक z axis है. So this gives you 3 dimensions. Then if you can move in between, it gives you a 4th dimension. And then if you can rotate, it gives you 5th dimension. अगर आप बैक के ऊपर आ रहे हैं, तो 6th degree of freedom. So ये degree of freedom decide करेंगे कि आप कितना काम कर सकते हैं. Your hand has a 360 degrees and 8 degrees of freedom. So इसके साथ robot की अच्छाई और बुराई होती है. So high capital इसके प्रॉब्लम में आता है डा-विंची के, बाकी चीजें ठीक है. दूसरा जो सा रोड सिस्टम है वो ये वर्सियस है. मैं इसकी आवाज बंद करूँ ताकि लगे कि मैंने खुद बनाई हुई है. अच्छा जी, वर्सियस जो सा है ये वाला मॉडल, इसके बीच में 2 आर्म्स अलग रहते हैं. They move the long, it is cheaper as compared to the डा-विंची सिस्टम, और लेकिन इसमें डिग्री ऑफ फ्रीडम निस्बतन कम है. और साथ में ये आर्म्स दोनों आपको आइडेंटिफाई करने की जरूरत होती है कि कहाँ पर लगेंगे और किस तरह से चलेगा. अदरवाइज दिस आल्सो गिव्स 7 डिग्रीज ऑफ फ्रीडम एंड स्मॉलर फुटप्रिंट है इसका, क्योंकि डा-विंची का भी आपको दिखाता हूँ. इट्स डिफिकल्ट टू मूव एंड डॉक. डॉकिंग तब कहते हैं जब इसको फिक्स करने की जरूरत होती है. देन कम्स द सेनहॉस सर्जरी है. सेनहॉस सर्जरी का रोबोट जो है ये ज़्यादा प्रिमिटिव किस्म का है. प्रिसीजन इसके साथ ज़रूरी है, लेकिन इसके बीच में जो आर्म है वो आप यूज़ करते हैं तो जैसे वीडियो गेम खेल रहे हैं उस तरह से मूव करता है, बजाय इसके कि हैंड रोबोटिक हैंड की मूवमेंट नहीं है. सो ये लैप्रोस्कोपिक हैंड की तरह जैसे इंस्ट्रूमेंट्स यूज़ करते हैं उस तरह से ये इस्तेमाल होता है. इसकी degree of freedoms थोड़ी सी कम है, लेकिन again this is one of the system that is being in use and can use. It additionally gives a haptic sensation. So जब आप किसी tissue को push करेंगे तो it gives you some resistance, तो आपको feel आएगी कि ये resistance आ रही है, जो पहले दोनों system हैं वो इसको नहीं करते हैं. Then comes the Hugo Ras. Hugo Ras is again one of the new system. Hugo Ras is important. Why? Because it is the only system that gives you reusable robotic instruments. So बाकी सारों के बीच में disposable है, ये reusable है. इसका मतलब ये है कि probably अगर कोई चीज़ आएगी हमारे पास जिसको हम कर सकते हैं, वो भी जो हमारे third world countries के साथ होगी, तो we already have all the new systems, तो वो काम कर रहे हैं. Lastly, Revo I है, very similar to the Da Vinci, or it again has almost all the features which are present in the Da Vinci system. Is kind of a copy of the same systems of robotics के साथ. So this is the last जो हम इसके बीच में देख सकते हैं. इसमें 7 degree of freedom है, इसके बीच में reusable tools हैं, and which makes it more important for use. एंडोस्कोपिक मिस्टेक्टमी के ऊपर हम चले जाएंगे. जो अभी रोबोट के ऊपर मैं भी जाता हूँ, these are all being reported in the form of a series, right? So you can use a laparoscope or a robot for this purpose. So if you're doing a nipple sparing mastectomy or surgery के point of view से, the only reported cases for robotics are the nipple sparing mastectomy. Other is for harvesting, and lots of work has been done for the LD flap and the DIEP flap and the PAP flap. लेकिन mastectomy के लिए, nipple sparing के लिए सिर्फ और सिर्फ इसका use है. So you put the patient in supine position, mark the vertebrae, और फिर auxiliary line के ऊपर आप 3 incision लगाते हैं और यहाँ से एक docking होती है. ये जगह बन रही है जहाँ से entry होनी है, और जब एंट्री हो जाती है तो ये यहाँ पे उन्होंने सिंगल पोर्ट यूज किया हुआ है. सिमिलरली यहाँ पे डॉक होके 8 मिलीमीटर के 3 पोर्ट्स डलते हैं, तो यहाँ से चला जाएगा. एंड दिस इज हाउ यू सी इनसाइड. सो एंड देन इम्प्लांट बेस्ड ज़्यादा यूज हो सकते हैं, इसके साथ करते हैं. दिस इज अगेन अ स्मॉल वीडियो ऑफ हाउ द डॉकिंग इज डन. दिस इज द डा विंची सिस्टम. और जो यहाँ पे सर्जन है वो पहले मार्क कर लेता है 3 जिस पोजीशन के ऊपर आती है. 8 मिलीमीटर अपार्ट 12 मिलीमीटर का पोर्ट है, 3 पोर्ट्स का मतलब डलने होते हैं. और फिर वो वहाँ से एक नर्स असिस्टेंट पीछे से उसको लेके आता है जिस लाइन के ऊपर फिल लिख हुआ है. जब उसने आगे आ जाना है तो यहाँ पे अपने आर्म को एक्टिवेट करना है. दिस इज ऑल मैनुअल. द असिस्टेंट इज स्टक, और वो आके पहले कैमरा पोर्ट अटैच करेगा, फिर उसके बाद दोनों वर्किंग पोर्ट्स को अटैच करेगा. सो दिस इज नोन एज डॉकिंग, and this is needs to be done. जो आपने CMR देखा उसके बीच में इस तरह का बड़ा कंसोल नहीं आ रहा, उसके बीच में there are different arms that are coming in. This one is, and all the other 3/4 have this console, so this would come and needs to be attached to the sector. और इसमें ध्यान ये चीज रखनी होती है कि जब मूवमेंट हो तो ये आपस में क्रैश न करे. ये कुछ इस तरह से नजर आएगा जी. सो यहाँ पर हेड एंड के ऊपर डा विंची सिस्टम पड़ा हुआ है. डा विंची सिस्टम जो है उसी तरह से इंसिजन आप देख सकते हैं जैसे पहले हमने मार्क किए थे. सो द होल ब्रेस्ट इज बीन मार्क्ड, और उसके बाद एंटीरियर एक्सिलरी लाइन के बीच में there are incisions, तो 3 incision बनेंगे. उसमें से 2 incisions को आपस में मिला के स्पेसिमेन को ट्रीट करने के लिए इस्तेमाल कर सकते हैं. इससे पहले जो रिपोर्टेड इस वक्त है केस सीरीज हैं, जो उन्होंने जो डर्मिस है वो पहले से आइडेंटिफाई कर ली, या एक्सपैंडर उन्होंने देख लिया कि एक्सपैंडर किस साइज का यूज होना चाहिए. तो सेम इंसिजन, rest of the operation remains the same. If we move on to the harvesting of the EIEP flap, so इसके बीच में there is much interest in this because the robot can help you take a very long pedicle, which is difficult to get if you do it open because of the morbidity. And this is a picture that shows the difference. That this is the incision made for the open technique, whereas this is the incision made for with the robotic arm, and the length is also different. So longer length has been reported will be taken out, so the time is longer, लेकिन इसकी morbidity बहुत कम हो जाती है. There are lots of, not lots of, there are few meta-analysis, and these are based on 22 papers. And there is another, and most of the, अगर आप sample size देखें तो the biggest is 142 cases. The rest is small cases, small case series, and they are doing it. So there is an article which shows that there is a bibliometric analysis of robotic surgery, and these narrative reviews, bibliometric reviews, they identify hotspots of research कि अगले 5 साल 10 सालों में क्या research के topics emerge कर रहे हैं. और ये स्टडी जो है ना ये शो ये करती है कि टोटल 177 आर्टिकल्स पब्लिश हुए हैं in the last 15 years on robotic surgery in breast surgery. और उसमें majority जो है is coming from Yonsei in South Korea and the published in the Asian Journal of Surgery. जो hotspots identify हो रहे हैं वो I'm sorry for this busy slide, लेकिन इसके बीच में मैंने कहीं hotspots या फिर मिल जाएंगे कि this study helps to researchers to quickly identify the hotspots and frontiers in the field, providing the references. और इसके बीच में robot surgery और DIF lab के ऊपर काम आ रहा है. Indication of robotic and the nipple sparing mastectomy are very similar. जो अभी तक consensus document में आया है वो they are very similar to what is for the open surgeries, the prophylactic mastectomies, small breast size with stage 2 or less tumor, adequate skin tumor at distance, stage 3A tumor with adequate response to neoadjuvant therapy, and no skin involved. Contraindication are large protic breasts, high aesthetic risk patients, pectoralis muscle and inflammatory carcinomas, or nipple areola complex involved. Technical consideration that the recommended incision placement is the inferior axillary line, and recommended skin slab development pre-docking with blunt scissors and then post-docking dissection with a monopolar scissors, and recommended intraoperative subnipple frozen biopsies and standard post-operative drainage. What we are thinking about is probably if we don't have the robot for the time being, but is it possible to make a flap away from the breast and take the specimen out from there? So जैसे हम यहाँ axilla से निकाल रहे हैं, इसी तरह से थोड़ा सा और भी नीचे आ सकते हैं. तो I think we have recently doing SCOLA, और SCOLA is subcutaneous on laparoscopically, and there we have raised the flap, और उस flap के अंदर हमारे पास बहुत सारी space है to manipulate. Robots are coming in all fields. So they are going to come in this area also, and so this was this presentation that I tried to complete. Thank you very much.
Thank you, sir. Is there any question? So now we are going to conclude our first session on the class of breast surgery and surgical options. So I invite Professor Rai and Professor Latifah to share student presenters. First, I like Dr. Huma Majid to come on stage and receive her degree. Next, Dr. Amna Khan. Thank you so much, all of you, for coming.
Thank you so much. It's so nice to see you.
Next, Dr. Ilham Najib. Thank you everyone. Now we have a small tea break, and then we go for the second session of classes. We have very small time for that. Already late. Thank you so much.